Good afternoon, everyone. I would like to request Professor Shalivasti ma'am to escort all the dignitaries to the dais. Respected Honorable Vice Chancellor Ma'am, Shally Ma'am, Head Department of Paediatrics, VL Bhatia Ma'am, Head Department of Endocrinology, SGPGI, Professor Malakumar Ma'am, esteemed guest faculty, distinct faculty members, my batchmates and staff members, a very good afternoon to one and all. On the behalf of Department of Paediatrics, I would like to take this opportunity to welcome you all to the Pediatric Endocrinology Update Inauguration. May I now request Dr. Shalivasti ma'am to escort all the dignitaries for our traditional auspicious lamp lighting ceremony as a tribute to Ma Saraswati. I will now request Dr. Shweta, Neha, Deepika and Bhumika to give floral welcome to the dignitaries. Honorable Vice Chancellor Ma'am. VL Bhatia ma'am. VL Bhatia ma'am. Shelly Awasthi ma'am. Mala Kumar ma'am. Indu Vakru ma'am. Archana Kumar ma'am. Preeti Dabadgao ma'am. Arpita ma'am. Singh sir, SN Singh sir. Dr. Avivar Avasthi sir. Thank you. I will now call upon our Head of Department, Professor Shelly Awasthi ma'am, to welcome our dignitaries.
A very good afternoon to all of you. Honorable Vice Chancellor of King George Medical University, Professor Sonia Nityanand, Professor VL Bhatia, Dr. Mala Kumar, Dr. Arpita, and we have as our eminent speakers Dr. Preeti, Dr. Vandana Jain, heading Department of Endocrinology, AIMS, New Delhi, who will join us shortly, Dr. Anurag Bajpai, Dr. Avivar, and Dr. Arun Pandey, who will join us shortly. It's really our unique privilege and pleasure to have our Vice Chancellor visit our department today. Ma'am, we are indeed honored, and I request you to continue mentoring our faculty and showering your blessings on the department. We were formed almost 70 years ago, and if you see the stones, the foundation stone was laid on 14th November 1954, and on 26th January 1956, the department was handed over to Dr. N.L. Sharma back then for running the department. Ma'am, in the last several years, for 3 consecutive years, we have been adjudged the best clinical department of the university. Over the last several years, we have been following the collegium approach, which has now come in AIMS. And it's not 3 or 4 or 5. The entire department sits and decides and signs on the papers where decisions are made. That has been followed. It is documented. We have 26 MD seats. 5 are permitted. A compliance inspection is due for recognition of these 9 seats. And after these 9 seats are also recognized, we can then have a further increase in seats. Till these 9 seats are not recognized, we cannot have further increase in seats. Ma'am, we are in 6 units for adjusting these 26 faculty residents. We have to have 18 faculty, and we are spread over 6 facilities. When we were students, this was the only pediatric department. Now we have hemato-oncology on top, looked after by Nishant. We have a neonatology across the road in Queen Mary, looked after by Dr. S.N. Singh and Dr. Shalini. We have a NICU in the 4th floor of Trauma Center, looked after by Dr. Mala and Dr. Shalini. We have a pediatric intensive care in the 4th floor of trauma, looked after by Dr. Siddharth and Dr. Sarika. And we have with us a pediatric emergency where we are admitting patients. So if you see our resident strength, including our senior residents, we are a lot, but if you spread across, and there are 6 labor rooms where deliveries are happening, emergency and cesarean, the numbers go very thin. Another thing, ma'am, is the district residency program, as you know. We have to send 1/3 of them there. So which again hampers our services to some extent. Ma'am, since it's your first visit, our OPD attendance is around 36,000. It was last year. Then admissions are around 10% of OPD, 3,000 to 4,000. And we take pride in excellence in UG and PG teaching, in patient care, as well as in research. When we were students, we had a neonatology unit by Dr. P.K. Mishra. That is continuing. A department of neonatology has been sanctioned. 2 times it was advertised. There was no applicant. We hope that the department becomes fully working and the inpatients are handed over to them. Then we have hemato-oncology, again started by Dr. Mishra, but championed by Professor Archana Kumar, who is here. We have a full-fledged department, but the department, there were no applicants for 2 consecutive times. Dr. Nishant Verma is ably managing that single-handed with the thalassemia clinic. Ma'am, the trend of subspecialty was always there. Neonatology, hemato-oncology. Then we have the pediatric intensive care established by late Professor Govil in our department. It is going on solid with Siddharth there. But subsequently, ma'am, pediatric gastro came up with Dr. Sanjeev Verma, who is in OPD today. Siddharth is in OPD. They run the pediatric gastro. And in the last few years, 3 years to be precise, we have developed pediatric pulmonology with Dr. Sarika Gupta, and bronchoscopy is now happening in our department, pediatric bronchoscopy. We have pediatric endocrinology, and I must highlight that Dr. Bhatia helped us a lot. And Arpita went and was trained under Dr. Bhatia, which is a big thank you, ma'am, because you accepted to build our capacity. Not only that, we would like to thank the Novo Nordic for their corporate social responsibility, and they have set up a center of excellence in type 1 diabetes here. Then pediatric nephrology, as you heard yesterday, ma'am, it's coming up in a big way. We will start our hemodialysis here, sledges here, and all other services with Dr. Punya joining back the department. And yesterday I found out that the RO plant ka repair baki hai keval kai din se. Jaise hi RO ka repair ho jaye, we will start our hemodialysis. So you know the change in scenario that we can have within our parent department 4 subspecialties. 4 are there blooming, but they will need another 10 years before the DMs can start in them. But 2 can immediately start, that is neonatology and in hemat-onc if we have applicants. But today we are here for pediatric endocrinology, which has come up in a big way. Every alternate emergency, we had type 1 diabetes in ketoacidosis. We managed, they were lost. Now they are not lost. She has built a WhatsApp group. We follow them up. We are trying to follow very big footsteps of Dr. Bhatia to the best we can, ma'am. And we hope you continue guiding and supporting us wherever you are, ma'am, because we will need that support from you. So also we have the congenital adrenal hyperplasias, we have the hypoglycemias, hypocalcemias, and today it's very apt that we have luminaries in the field of pediatric endo and a budding pediatric endocrinologist who have come to give us lectures today. And we hope that with your blessings and mentorship, all the subspecialties will bloom and thrive and reach newer heights. Thank you very much for inviting me.
Thank you, ma'am, for your kind words. I would like to call upon VL Bhatia, ma'am, Head Department of Endocrinology, SGPGI, to address this gathering.
Thank you so much. For me, it's a pleasure and a privilege to be here again.
When I first came to Lucknow 33 or 34 years ago, I didn't know anybody here, absolutely. The first pediatric colleague whom I came to meet as a senior and as a friend, former friend, was Dr. Rashmi Kumar. She was 4 years my senior during MBBS. And 4 years senior means like I must have hardly had that much of a relationship, except a very like a respected senior who has, done so well, etc. Because we didn't overlap so much otherwise. But when I came to Lucknow, everyone said, Dr. Rashmi is there. And ever since then, there's been no looking back. All my friends and colleagues in the pediatric scene have been here in this hall. And Preeti and I used to come so many times when we had on the Saturday afternoon, 2 o'clock teaching sessions in this hall. We had a very, very good learning and good relationship friendships which we have built up and became collaborators also over the years. So it's really a privilege to be here, and I'm so happy that all the successive HODs and Arpita have made established pediatric endocrinology nicely over here, and are taking it forward in such a nice way. I wish you all the best, and I wish the department all the best. Thank you so much. Thank you, ma'am, for your kind words. I will request our Honorable Vice Chancellor, ma'am, Sonia Nityanand, ma'am, to bless us with the kind words.
Thank you. So, Dr. Vijayalakshmi Bhatia and Dr. Shelly Avasthi, Dr. Mala Kumar, Dr. Arpita, Dr. Archana Kumar, Dr. Preeti Dabarghau, and many, Dr. Essenson, many other senior faculty members who are present, esteemed faculty members, I would say, in this audience, the residents and the students who are attending the CME today. It gives me a lot of pleasure to come to this department because it brings back the memory of my MBBS days. The department is same, of course, it has expanded. And when I went through the training here, Dr. P.K. Mishra was the head of the department, a very good teacher and a very learned person. And Dr. Indu Vaklu was number 2. And then we had the Kumars, Dr. Rashmi Kumar and Dr. Archana Kumar. They were young faculty members whom we could more easily relate to. And Dr. Shelly Avasthi had also become a faculty member. And I have very good memories of all of them, of the good teaching standards of this department and the enormous load that the patient load that the department shouldered. And of course, my memory of Dr. Mala Kumar is, most of you will not know that she had hair which were up to her knees. So she used to have one plait, very thick plait, which used to go down to the knee, So it was very, very nice memories it brings back. Yesterday, I have not visited the department because I started soon after joining with the assessment promotion interviews. And yesterday it was pediatrics and 2 super specialities of pediatrics, 2 faculty engaged in the super specialty of pediatrics were interviewed. So it gave me a feel of how the pediatrics department is developing here at KGMU, because one of them is focused on pediatric endocrinology and the other faculty was focused on pediatric nephrology. And it was very, very nice to see that the department is moving towards developing units of subspecialization. Okay, you don't have separate departments, but it is good under the umbrella of pediatrics that there are subspecialties where one can go more into the depth of setting up investigations, setting up management techniques, and doing research in those areas. So I would like to compliment the Department of Pediatrics for moving in that direction from general pediatrics to subspecialties of pediatrics. And one cannot undermine the role of pediatric endocrinology. You know, Dr. Vijayalakshmi Bhatia is like an icon in pediatric endocrinology. I mean, she has really set up beautifully within the Department of Endocrinology in SGPGIMS, a pediatric endocrinology unit. And now I think there is a separate department, or in the verge of being made into a separate
Trying to get made.
Yeah, I know when I was there, we had presented it to the chief secretary, you know, a Department of Pediatric Endocrinology. But nevertheless, even if it's not there, it's an excellent unit. It really doesn't matter if there's a department or you work within the Department of Endocrinology. And she has not only set up the services for pediatric endocrinology in SCPGI, but also gone into deep research areas of pediatric endocrinology. You know, especially growth and development of children, and you know the diabetes part of it, the type 1 diabetes part. So I'm so happy that she has. I mean, we would like to thank you also that you've helped to develop this specialty in KGMU also. I mean, there's no one like you actually in pediatric endocrinology. So we'd like to express our gratitude to you and hope we get more support and help from you in taking it to higher heights. And Arpita, I would like to congratulate you. I heard you talking about how you have developed the field, and it was very heartening to hear that, because in children it's an emerging problem now of thyroid, of growth, of pubertal changes and pubertal problems, especially precocious puberty, and of course type 1 diabetes and several bone disorders also. So with these few words, I would like to thank the organizing committee for calling me here, and I hope all the participants have a very fruitful CME today where they gain knowledge, and I hope it induces some of the young residents to get into this field of pediatric endocrinology. Thank you.
Thank you, ma'am, for your words of wisdom. Your guidance and presence is a constant source of motivation for all of us. I would like to request Mala Kumar ma'am to address this gathering with her kind words.
Thank you. So this brings us to the end of this inaugural session. And I'd like to take this opportunity to thank, to begin with, I'd like to thank Professor Sonia Nityanand for sparing time for us, for coming here and gracing this inaugural. And that really gives everybody a big inspiration and hope to do better, because it's nice to be seen if you're doing something good. Professor Vijayalakshmi Bhatia, the more we thank her is less, because she's so humble and so approachable. Even in the middle of the night, you send her a message or send her an email. I think sending emails is better, because she will revert. And she'll tell us the nitty-gritties. वो टैबलेट होगी, वो उसको 1/4 करना है, अभी तुरंत डिसॉल्व करके तुरंत देना है. So all those things nobody shares actually. She's learned those things over the years. She's taught those things to many, and she never misses an opportunity to pass on that knowledge to others. She's so very approachable. Thank you, Adam, for being there for us all the time. Then I'd like to thank Dr. Avivar, who has come all the way from Manipal to be with us today, and Dr. Sharma, who's here, who's helped us in a big way. I also thank Dr. Archana Kumar and Professor Preeti to be here with us today. I take this opportunity to thank all the other faculty members of the department, all the participants. Without participants, there's no fun. So, like they say, कि जंगल में मोर नाचा किसने देखा? So the more is going to dance. but there are so many admirers who are there. So without you, the CME would be fruitless. I also thank the residents who helped out, the support system in the department that helped with the arranging of things, and the sponsors who magnanimously helped us to set up this CME. So thank you once again, everybody, for being here, and have a wonderful time. Enjoy the CME, and that's all that I have to say. Thank you so much.
Thank you, ma'am, for your kind words. I would like to request Professor Shaili Awasthi, ma'am, to kindly honor our Honorable Vice Chancellor, Sonia Nityanand, ma'am, by presenting a memento to her.
KGMU. Okay.
I would now request Arpita, ma'am. I would now request Mala Kumar, ma'am, to present memento to VL Bhatia, ma'am. Thank you.
So I would like to request all the faculty members and the guests speakers to come to the dais for a group photograph.
And all the faculty of department, please come and ma'am, actually, ma'am, आपकी तो faculty है. Yes. Come. आगे ये बंद करा दो.
आप लोग बैठ जाओ, पीछे रहेंगे.
Yes, ma'am, I know this is all right. And she has no concept.
ये और मैम का ये PPT है.
I would now like to invite Professor Shaili Awasthi ma'am and Archana Kumar ma'am to introduce our first speaker, Professor V.L. Bhatia ma'am.
We'll sit down after introduction. आप करेंगे कि हम करें? I have something in writing. आप कर दो, you know, मैम. मैम आ जाइए. अच्छा. It's my pleasure to introduce Professor Vijayalakshmi Bhatia today. Dr. Bhatia did her MBBS and MD Pediatrics from All India Institute of Medical Science, Delhi, and her Pediatric Endocrinology Fellowship at the University of Massachusetts Medical Center, USA. She has been a faculty member in Sanjay Gandhi PGI Institute of Medical Science, Lucknow, where she started first fellowship program of Pediatric Endocrinology in 2001. She has served as a secretary and chairperson of Pediatric and Adolescent Endocrinology chapter of IAP and president of the Indian Society of Pediatric and Adolescent Endocrinology. Her publications are in the field of vitamin D, calcium, nutrition, type 1 diabetes, and disorders of sexual differentiation. Ma'am, it's a pleasure to have you, and it's a very small introduction, and what you are is much beyond words can say. Please, ma'am, come forward.
Thank you all. Thank you, Dr. Shaili, for your kind words. And I really have to say, because too much was said about V. Bhatia and endocrinology. After I joined STPGI, within 3 years or so, Dr. Preeti joined for DM. She's an MD Pediatrics background who did DM endocrinology at our place and then went abroad for some fellowships, and then we were so lucky that she joined back. And all what our pediatric endocrinology unit has set up and done, worked with the patients, and whatever publications we have is all because we had a solid combination of both of us for a long time. So everything is shared between the two of us. And after that, we were lucky to have for several years Dr. Siddharth Sudhanshu. Many of you have interacted with him also. So we had a very solid team, actually. So without taking more time, today my brief is to talk about type 1 diabetes management, little bit about the current management, and little bit about how we can improve in the future, like what the international leaders are showing us the way. So currently, our child and her family are with a new diagnosis of diabetes, sad, angry, depressed, confused,
and we are having to, look after this child and the family and make them fit for looking after themselves in the years to come. She is surrounded by pain, pricks for blood sugar testing and insulin many times in the day. She has to observe a lot of discipline and a lot of tasks all through the day. Recording blood sugars, interpreting what is low, what is high, taking some decisions, obeying certain rules, mainly discipline. Not too much of restriction in food, but the discipline that you can't do anything. You can't play, you can't eat, you can't go out anywhere without first thinking about your diabetes. And imagine that if we have to live like that 24/7 all through life, that before we can spontaneously do almost anything in our life, go to school, participate in PT, share the tiffin with the friends, anything in our life, we have to first think something about the diabetes and then go forward. Imagine what a burden it must be. So the task of technology actually, and they have achieved it, is to decrease the burden so that the child feels more and more free from a burden, and the family also can sleep at night and can have a less burdensome and more free life. So the current treatment, what we give, natural insulin, is regular and NPH. I am sure in SGPGI also we treat everybody with regular insulin and for prandial insulin, and NPH for a good number who cannot afford the analogs. And I'm sure you all must be also. But analogs have come in recent times. The fast-acting analogs have certain advantages, that the gap between the insulin and the meal can be just 15 minutes. So it's very convenient for toddlers. We do use it for toddlers where the mom just cannot predict when the child is going to eat. So she can give the dose closer to the time of the meal, or she can give half the dose prior to the meal and then half the dose during the meal. So though it's costly, we do use it for infants and toddlers, and it mirrors the blood sugar rise very nicely. And then this long-acting or peakless analog, which takes the place of NPH, we really use it. Even if the patients are, a little bit affording, we do lean on them to say that your child will have much less hypoglycemia if you use glargine instead of NPH. So we do use it quite a lot. The conventional regimen that we used to use, we don't use this even in India for the last 30 years. So it was regular and NPH in the morning, regular and NPH at night before dinner. But ever since it was realized that so the two green circles show up that there is uncovered action of insulin between the major meals, lunch and dinner, and breakfast and lunch and dinner. And those can be accommodated by the usual lifestyle of a child. Children usually will have a mid-morning snack at school or at home, and they will have a tea time snack in the evening. So these areas where hypoglycemia could have occurred in a major way are covered by small snacks, which are natural in the life of a child, but not necessarily natural for adults. For them, we had to teach them कि NPH ले रहे हो तो snack खाना है. It's not necessary with glargine. But the high of lunch is not covered by any insulin in a sharp way, as you can see. And so people moved on to what is called modified basal bolus by giving another regular in the afternoon at lunchtime. So at the very least, 3 regulars with the 3 major meals and 2 NPHs. This is how one would do, and mostly it is called modified basal bolus. Why modified basal bolus? Because typical basal bolus is analog, that is rapid analog, and glargine or detinol for the long acting. But actually, there is a small peak produced by even the snack. And for school children, they eat a small breakfast and a large tiffin with paratha always. So a good amount of glucose is released due to that. And also the evening snack is good. So we almost by adolescent age, we pester the child and the parents to accept evening snack regular insulin. Doesn't matter if the gap between the lunchtime and that evening snack insulin is only 3 hours. It's a little top-up dose. Supposing lunchtime is 8 units, give that, say, 2 units or so with the evening snack, so that the evening sugars and the pre-dinner sugars are well maintained. And we do try to tell them to take also regular insulin or rapid insulin with the pen at school, also with the school snack. But unfortunately, the social stigma, the awareness and all is so poor in our region that children do not accept. So we cannot go against what would, if they would feel uncomfortable at school, that's the last thing we want them to do. So we don't pester them. So this would be the kind of regimen which would give least hypos with reasonable blood sugars. And of course, the night hypo produced by the NPH would be taken care of by trying to change, if the family finances allow it, to change from NPH to long-acting insulin like glargine or tetinol. But still, so I put the slide to say there's a great pressure from the adult endocrinologists and diabetologists and therefore industry to know what is this pre-mixed insulin. It's a fixed ratio of regular to NPH or regular to long-acting, and fixed ratios are not good for pediatrics. So I'm really stressing this, that pre-mixed insulin 30, 70, 50, 50 should not find a place in our prescriptions at all. Now, life is made a little easier by other devices for taking insulin instead of the insulin syringe, which has the advantages of being cheaper than a pen. A single prick, if there is a mixing between regular and NPH, one can use a single prick by mix, and it's easily available in small towns. Maybe good pens are not available in small towns. But the advantages of a pen is accuracy and easy to use. It's less threatening, like it doesn't look like a big fat needle, for a small child, and the needle sizes are small. And I must say that even though the use of the pen demands that we use a cartridge instead of a vial, and the cartridges of U100 are even regular and NPH, the cartridges are costlier than the vial of U40. But no parent till now has said because of the cartridge cost of regular and NPH, they would like to go back to the needle. The pen is really convenient. So, and the companies give the pens free. So little bit of higher cost for the cartridge. Analog cartridges are much costlier. They are about 2.5 times costlier, but regular NPH are not that much costlier than the vial. But our little girl is still sad, even despite having the pen, because she has to observe a lot of discipline, learn a lot of things. This is a minimum checklist of knowledge. This is just a cartoon, change your rotation site, do this, do that. So many tasks which they have to remember. Test 3-4 times a day if money for blood sugars is not an impediment. So we need more technology to help our children. Just a little word that why do we pester the children to do monitoring many times a day if finances is not an impediment? Ideally, pre and 2 hours post meal every day and midnight daily, ideally. But really, we would be, coming in the way of the child having a good sleep and the parents having a good sleep. So we decrease it in a practical terms. We advise 2 to 3 pre-meals daily, and often a bedtime test and midnight test maybe once in a week or once in a fortnight. Unless if there is a hypoglycemia, then the very next night they should do it again, just to make sure it's not a repeated thing. But why do we do this? We do it because even though it is causing pain for the child to, finger prick every time, we do it because we expect and teach. And without this teaching, there is no use of keeping on testing. So we must teach that for an intended next meal, if it is going to be a larger than usual meal, the child family should adjust a little higher dose of the prandial insulin, and vice versa for a very small carbohydrate meal. And secondly, every pre-meal which is high should also be compensated with a little extra insulin. So these are the reasons why we test. If we don't test, we will never know that the child was 300 before the lunchtime. And if the child was going to have a nice birthday party snack, the child won't adjust and take extra insulin. So that is why we test all the time, before and after. They reflect different things. Before meal reflects the long-acting insulin, and after meal reflects the prandial insulin. Was it correct or not? Only the cost of strips should be an impediment. Otherwise, if the child changes the lancet with every prick or every 2 pricks, they get used to it. It's not our job to be, we should be empathetic, but we should not let it come in the way of a proper instruction from our side. We should be soft, but we should be empathetic but firm in our advice that the child must test. So a new technology, which is not so new anymore in Lucknow, is CGMS, Continuous Glucose Monitoring System. And one of the students, Tuba, had actually done her thesis on this. And I'm sure because of her thesis and the guidance, everybody, all of you came to know about this. And the impediment, yes, is cost, but otherwise it's really a boon. Between CGMS and pump on the other side, which are the 2 new technologies, CGMS is really a boon. So what is CGMS? The child wears a small sensor. This is a small sensor, the size of a coin. This is from a company called Medtronic. So this sensor is worn on the abdomen and it's just inserted into the subcutaneous tissue. And the other company, another one, is this one. It is put behind the arms from Abbott. And this senses the tissue glucose every 5 minutes in the Medtronic and every 15 minutes. Actually, it senses continuously, but it gives a reading every 15 minutes in the Abbott sensor. A transmitter in the case of Medtronic and the reader in the case of the Abbott, they give the readings. And you can see in this little meter here, the reading is showing. So there is a strong correlation between the blood glucose and the tissue fluid glucose. So the tissue glucose is a surrogate for the blood glucose 5 minutes back or 15 minutes back, respectively. So without finger pricks, the child and family can know the blood sugar just by waving the reader near the sensor anytime. And they just have a few 1 or 2 requirements, like they have to, bring that thing nearby at least once in 8 hours. It shows trend arrows. Is the sugar falling fast? Is the sugar kind of same for the last few hours, or is it rising? Based on the trend, if we teach the family nicely, they can preempt hypoglycemia. So it's really a boon. I will tell you about the cost. The cost of this Abbott one is real-time sensor is about 4,000 rupees per sensor, lasting for 14 days. So that would be about 9,000 rupees a month extra. But if the family can afford or get reimbursement, it's a boon. So this is how, if we do capillary blood glucose, let us say 4 times a day this child has done, the 4 readings are largely within the expected range or ideal range of 70 to 140 milligram per DL at various times of the day. But if a sensor was worn, it had shown these huge glycemic excursions, well up to 300 milligram per day even. So the use of the sensor actually tells in real time what happens in the whole 24 hours, not just in those 4 or 6 times when we can do the blood glucose reading. And so just like we all are familiar with HbA1c, how much is normal, how much is excellent control, how much is moderate control, like that now we have to be familiar with CGMS metrics, they are called. And there is a thing called time in range. It's just English meaning of it. How many hours of the 24-hour period we spent in ideal range, like 70 to 180. If you're very tight to control, 70 to 140, otherwise 70 to or 80 to 180. So something like that. We can set it ourselves. Mostly people set it at 70 to 180. So ideally, we should spend 70% of our time in range. Ideally, hypoglycemia less than 70 should not be more than 4% of the day. And you know what we all have? Like 15%, our children, sometimes even more than that. The well-taught children are spending even now with analogs and glargine analog and everything, are spending 10 to 14% of their day in hypoglycemia. What is it doing to their brains in the long term and in the short term also? They are students. Time above range should be less than 26, and there is something called glycemic variability. It's a coefficient of variation actually that should be ideally less than 36, and hardly any 4 or 5% of our children are having a glycemic variability less than 36. So real-time CGMS has been shown to improve all of these metrics. This is how the CGMS output looks like. Each day of the week for the last 1 week is having a different color, and the excursion throughout the 24 hours is being seen in a different color. It is a very good educational tool. There is a retrospective CGMS also, which only costs 2,200 or something, and that also we can wear for 14 days. Same company from Abbott, and then we can download it into the computer and share it with the patient to make them understand. If somebody cannot afford real time, we can use the retrospective one maybe once in 6 months or so, just to share with the family that how is the pattern looking for the last 14 days. So it's really useful. This is a Medtronic output. And this particular child, you can see every day of the week. See, each different color is 1 day of the week. And every day of the week between this 9 o'clock and 12 o'clock or 1 o'clock when the child is at school, see how high the excursions are going. When we began seeing these kind of excursions with our first few patients who used the CGMS, then we understood that what is happening in the school. The breakfast, the parents don't want to give a good dose of regular. They're afraid for hypoglycemia during school time. And the tiffin is a good hefty tiffin. And all this is resulting in huge excursion during the school time. We also did a project to address this, how troublesome is this for our children. And other metrics described below, they're very useful to see all this and explain to the parents. Like, this is each day of the week, 8th February, 9th February, etc. And it is telling percentage of sensor values. Highest is 218 on that day, lowest is this much, average is this much, etc. And for each day of the week. And then this one below tells that in the whole, like it's a pie chart, and how much fraction of the day's sugars were. It's like a TIR, were above 180, 70 to 180, and below 70. So for each day of the week, it's showing the metrics. These are very useful for the doctor to understand what's going on with the child and also to explain to the parents. I'm just putting up only one slide to show that this same, why did this come out only in 2022 in a very good journal? That's because this intermittently scanned sensor, the one which is cheaper than the Medtronic, that's the Medtronic had 2 decades of advantage over the other companies, and that one is much costly for use in India. So in India, this intermittently scanned from Abbott is a very common thing used all over our country because it's half the cost or less compared to Medtronic. And so from other countries, from developed countries, the papers on intermittently scan have been coming later. Otherwise, these kind of landmark papers started coming in 2017, etc. So here is the paper which is showing that the HbA1c in the blue line is the usual care, and in the orange line is the intervention, the patients who were given this sensor to be used. And there is just over a period of 24 weeks, there is a change of HbA1c of more than 0.5%, a clinically significant change of HbA1c. And there are other metrics like a decrease in the time below range, etc. So there is a huge number, profusion of papers suggesting nobody has got a negative result on this, other than the convenience to the child and the lack of pain. Moving on to another technology, that is the insulin pump. So the pump, we have very few patients on the pump because using the pump consumables day after day, month after month is expensive. But a little bit of experience Dr. Preeti has with pregnant patients and a couple of children we have. So I think in the private scene, there are more affording patients for a pump. So the pump, as the name indicates, pumps regular insulin or rapid insulin throughout the 24-hour period. So it pumps at a basal rate, which takes the place of the glargine, and that goes automatically. We can set different basal rates for the daytime, for the night time. If there's nocturnal hypoglycemia for the child, we can set a lower basal rate. Early morning dawn phenomenon for adolescents and adults, we can set a little higher basal rate. So we can set all these beforehand. Nobody has to wake up at 5 o'clock and increase the rate. These are already programmed into the pump. But the boluses for meals and snacks have to be done by the family. So these are all called hybrid closed loop. That means hybrid means the basal is going on its own and the bolus has to be done by the patient. I will tell about advanced hybrid also in a short while. So what are the advantages? The ability to have multiple basal rates, adjustable timing and shape of bolus, I'll show you. Only one insertion once in 3 days. So it's very nice for toddlers. They're afraid of needles. You can't talk to them and explain the things. So it's really nice. Only once in 3 days you have to replace the cannula. And very precise dosing in small infants and in pregnancy. The dosing can be changed by very minutely. So many of the problems with conventional insulin can be taken care of by the pump. Like you can have smaller boluses, bigger boluses for smaller snacks or bigger meals. Midnight, you can set a less basal rate for midnight to avoid midnight hypoglycemia, higher rate to combat dawn phenomenon, etc. So in short, risk of hypos and the need for discipline in timing and nature of meals and exercise is cut down. This is the same slide. I'm not going to. The next slide is from Dr. Raman, and he had given us a lecture and I took his permission to keep it. So this shows that, let us say this is the target blood sugar range, 70 to 140, let us say. And if the child took a pizza meal in the evening, it can result in hyperglycemia in the near term, and it can result in hyperglycemia through the night and morning because it has a lot of fat. So the carbohydrate as well as the fat, huge amount of fat, gives a delayed hyperglycemia. So with this kind of a meal, these three verticals are the prandial insulin, the bolus which the child has to tell the pump to release, 1, 2, and 3. But so because of the pizza, they chose to give either a square wave bolus. So this bolus will not come over just immediately. It will go over a long time. And you can also choose a dual wave bolus. So you can tell the pump that give 40% of my bolus now and 60% over the next 2 hours. So that takes care of the now for the pizza, and a slow long bolus to take care of many hours subsequently. So with these kind of things, one can play around with the type of food and the type of bolus. So I already said, ability to have multiple basal rates, you can program them. Every Saturday I go for my sport or my dance class, you can program it that for that much period of time and subsequent few hours, because hypoglycemia, exercise can induce hypoglycemia for a long time. You can program it to have that only on Saturdays, this is my temporary basal rate. During times of illness, you can feed a temporary basal rate to be higher. So one insertion every 3 days. And disadvantages, you have to test frequently. You have to put that knowledge in your brain, process it, and then tell the pump to to give yourself more insulin or program the new bolus. So that burden of knowledge is not gone. The burden of testing is not gone. So these are the disadvantages, and adolescent patients often dislike something to be attached to their body. So this is an extra thing to be attached to the body. They may not like it. In India, cost definitely is a big problem. But I put this because it was Ram Menon's slide several years ago. And at that time, how life has changed. At that time, there were all these criteria. Only after 6 months of education and these many months of doing basal bolus therapy, etc., evidence of monitoring and recording blood sugar at least 4 times a day. All this is finished right from day one, and especially for the little children. go for pump. So life has really changed because of the experience of this technology. So supposing this pump and this output of the CGMS could talk to each other. The CGMS could send out the signal to the pump that at this moment, this is the sugar. At this moment, this is the sugar. And it would be received by the receiver in the pump. Then wouldn't it be like our pancreas if the pump could actually put out that much of insulin which is necessary, which the CGMS is telling according to the sugar at this moment. So this is the artificial pancreas. And several decades ago, this is how big the artificial pancreas was. This was like the patient couldn't walk around. He was on the bedside only, like with the pump and everything in a backpack and all this. But as technology has changed, now there are wonderful pumps. Among the generation of pumps, some of these words you will want to know is low glucose suspend, and I'll show you in the next slide. Another one is predictive low glucose suspend. If the CGMS is showing a trend towards low, a rapidly changing blood sugar towards low, the pump will understand that, and before the blood sugar actually reaches 70 or 60, it will actually start decreasing the basal rate. So predictive low glucose suspend. And the actual complete artificial pancreas. So in the next slide, let us see this first one, sensor augmented pump therapy. This was not like an artificial pancreas. Here, the CGMS was separate, the pump was separate. Inside, in between, the human brain had to do every piece of the work. They were not talking to each other. The CGMS output was only seen by the person, and all the actions for the pump were actually done by the family. But the presence of that CGMS alongside the pump greatly improved the control and all the metrics as compared to only pump. Then the world realized that the CGMS is actually a bigger boon than just the pump. In the insurance and in the NHS and all in UK and all these Canada and all these countries, first the pumps were given free by the government. Only afterwards people realized that more money is to be saved by the government by preventing hypoglycemia, DKA admissions and hypoglycemia admissions and long-term complications by actually supporting the CGMS. So then CGMS started being supported later. Now everybody knows that CGMS is actually a more useful thing than just the pump, or the two together, of course. So sensor augmented pump therapy is just you set up lots of these are all different basal rates, like a normal basal rate, a little higher basal rate for that time when we are, at school and eating all that tiffin with parathas, and then a low basal rate to prevent nocturnal hypoglycemia, right? So the human brain has to do all this work. Then comes low glucose suspend. In this, the CGMS is talking to the pump only this much, that as soon as the CGMS records that the blood sugar has reached 70, not blood sugar, the capillary glucose sugar, but then the reading which comes out, it has been the equation between the tissue glucose and the blood glucose has been already fed in. So what we read there is a surrogate for the blood glucose itself. So when it reaches 70, the pump has stopped. Sorry, this is not moving so nicely. The pump has stopped, and it will not put out any more insulin until the blood sugar, the capillary sugar again reaches 70. Okay. Now this is little different from the next generation called predictive low glucose suspend. And here you can see that already when the blood sugar is 90, already the pump has stopped putting out a basal rate. And when the blood sugar has gone above 70, it is again resuming. So this is predictive low glucose suspend. All of these are available in India. So the impediment for us using it is actually not only the pump consumable, I'll show you the costs, but actually the cost of wearing the CGMS continuously, because then only the pump will stop. When it knows from the CGMS that we are reaching 70 or etc. Otherwise, how will the pump stop? So this using the CGMS continuously is the cost, more of a cost impediment. Lastly comes the hybrid closed loop. This is the artificial pancreas, where a very sophisticated mathematical algorithm is changing these basal rates. You can change, it is changing continuously. Continuously, the computer chip is sensing how much is the blood glucose and what is the trend. Like here, there is a trend of blood glucose going upwards, so the basal rates are increasing, you can see here. And here there is a trend of glucose falling down, maybe the person is exercising, so the basal rates are falling. So they are very closely tied to each other. Doesn't have to wait only till it reaches 70 or close to 70. All the time it is continuously working to change the basal rates. This is like our pancreas. So what is this wonderful computer algorithm? The mathematicians and engineers have set up, biomedical engineers, they have set up 2-3 different kinds, and different people in the world, different groups working in the world have used different mathematical algorithms by which the computer will predict that now this is what is happening. And they use like artificial intelligence, what had happened in the history of that child yesterday, last week, etc. That how had it responded? How had the blood glucose responded when the pump had done this kind of action? And then it further improves upon it. So there are 2-3 different kind of algorithm. I won't go into detail. So you can see that here also, when it reached 70, the pump stopped putting out any basal rate. And the beauty of it didn't let it go below 70. So it dampens out the amount of hyperglycemia and hypoglycemia before itself. Now are the costs. These among these, this Medtronic and Ipsomed are available in India. This slide is by my former student and colleague Lokesh. And this Medtronic 780G, this is the artificial pancreas. This has the algorithm to put out to fine tune the insulin delivery so nicely. And this was hybrid closed loop. I already explained what is hybrid closed loop. What is advanced hybrid closed loop? Little bit of the bolus action is also being taken care of by the pump. That is, some amount of estimated bolus delivery for a meal is being taken care of by the pump. Not in a very perfect way yet. I'm sure the day will come when boluses also can be taken care of. There are some research studies actually, but this is a bit more advanced than the simple hybrid closed loop. So some bolus activities happening on its own, mini bolus corrections. So this is really fantastic. If money was not an impediment, how nice this would be for the family. Cost. The one-time cost is not so bad in India. Many people could have afforded, but the recurring cost is the problem. So rupees 5,000 per month for the pump consumables over and above whatever they were spending previously for their diabetes care. This is for the pump users. And CGMS users is about 15,000 per month extra for the CGMS. So it is the CGMS which is actually killing. This is the amount. So if they have reimbursement or if money is not an impediment, in India, we can actually go for it today, this artificial pancreas. And we do. Many colleagues in the private sector are very much using it. And even, 1.5 in the government sector also. I want to say that all this knowledge, until last year or until all this artificial pancreas came, knowledge still had to be given. Otherwise, it's the family who has to respond to the sugar which is being seen in the CGMS. It's a big burden. Imagine it takes so much for us trained people to understand all this. How can a lay family, non-medical family understand and a little child appreciate all these things? So knowledge was it's a big burden. But hopefully with the coming of the artificial pancreas, the burden of knowledge requirement and the burden on the team would decrease. But psychosocial support will not go away anywhere. This is very important. And because we don't have so much of mental health professionals in our teams, like in our departments, we all have to become partly counselors and psychologists to support the family. So support group camps and support group meetings, day meetings, and with activities and food and little fun and some lectures. All of these are very, very important. So in summary, use the type of insulin most suited to that particular family. Less costly insulin can be used with good teaching, like to make a modified basal bolus regimen. be aware of the technological advances, because when the cost decreases, we have to use these for our patients. So we have to know about it. And ikka dukka here and there, we will have a very affording patient in front of us. So we have to keep abreast of these technologies also. And education and psychosocial support are crucial. Thank you so much for your attention.
As usual, that was a beautiful lecture, so well explained, and you really built up how things were there and what are things are now, with the cost and how important all of this is. It was beautifully explained, Dr. Vijayalakshmi. I think everyone could have understood it so nicely. And I have learned a lot from this because, medical science is rapidly advancing and we all of us have to keep abreast of it. Now, if there are any questions from the floor, anything you want to be explained better to you, or
Sometimes after Tuba's project, do some patients afford even a retrospective CGMS sometimes? Not yet. Okay. It's a useful tool. 2,000 rupees, and the reader they will give you free. So it's a very useful tool to explain to the family.
our GDP is increasing. So maybe there'll be a time when more and more people will be affording, and all of us need to be aware of all this, because we can't send all our patients to the endocrinologist. Yes, they can teach us and bring them back to us. And thank you for that beautiful lecture. Thank you so much.
I would like to request Archana Kumar ma'am to present a token of gratitude from us to VL Bhatia ma'am. Thank you, ma'am. I would like to invite Professor Mala Kumar ma'am and Shalini Tripathi ma'am to introduce our next speaker, Professor Preeti Dabadgao ma'am.
Dr. Preeti has made our lives impossible. She's refused to tell details of herself. She says, "I'm just Professor Preeti." And Dr. Vijayalakshmi Bhatia has already introduced her to us in a way that she was a very good student and she did her DM under her, and that now she is a faculty, a colleague, and they're in the same department. So, Professor Preeti, here you are.
Thank you, Mala. Actually, being introduced as a student, a former student, and the first pediatric student of Professor Bhatia is good enough. And so, whatever I say correct is her teaching, and whatever mistakes I make are mine. Yeah. So actually you learned or you got introduced to a lot of aspects about management of type 1 diabetes. My job is to make your life difficult and tell you and give you an idea that all children who come to us, as we have been taught up till now, and at least what we learned, maybe in undergraduate and postgraduate you have learned differently than what we learned, that 99.9% children coming under the age of 18 with acute weight loss, polyuria, 400 blood sugar is a type 1 diabetes. You put everyone on insulin, and we didn't have so many things to learn. It was practically giving everyone regular insulin, and if we were brave enough or our teachers were brave enough, we would have NPH. Otherwise, all our children went on 3 doses of bolus plain insulin. That is how I learned my endocrinology or management of type 1 diabetes. And in 93, when I joined here, that is the time when I gradually got introduced to that, no, we have to use NPH, and then the physiology of diabetes I understood better. But now my job is to make you understand that children who come with polyuria, have high blood sugars, all are not type 1 diabetes. We have to think beyond type 1 diabetes in this age group. And why is that so? What I'll do is, in a brief talk, I would give you an introduction of what is diabetes, the classification, and then why we should think beyond type 1 diabetes in certain group of patients, and give you examples from our own clinic, which ma'am and I have shared, and Sidnath, between the three of us, we have shared these cases, just to highlight that presentation may be fairly similar, but if you go into the depth of history, do some investigations, look back on that child and see the evolution of the disease in that child, you start thinking differently. And why is it important to do so? And probably a take-home message that we still have to think beyond type 1 in children. So as we know, this is the standard classification of different types of diabetes, which is based on the etiology. Diabetes has been classified based on the etiology. Earlier, we used to call it as insulin-dependent diabetes or non-insulin-dependent diabetes, which was type 2. But we realized that even type 2s require insulin once their beta cells fail. So it got changed into what is the etiology which is causing the diabetes. We know that type 2 is because of insulin resistance, whatever may be the factor, and we as a population are at a high risk of having insulin resistance even at normal or low BMIs as compared to the West. That is why the prevalence of diabetes or the number of people being affected with type 2 diabetes in our country will exponentially rise. And we should be aware of how to manage these children if it occurs at a younger age, which we are seeing. Unfortunately, we don't see so many type 2s in our clinic, but people in the private clinic or where other centers do see a lot of children with type 2 diabetes. And the last group is where there's a specific cause for diabetes in the form of genetic mutations like maturity onset diabetes of young or neonatal diabetes, insulin action defects, or defects in the exocrine pancreas, which will involve the beta cells leading to diabetes, secondary to various endocrinopathies like GH excess or hypothyroidism or excess of catecholamines. All these can have hypoglycemia as a part of its manifestation. Various drugs which are used in management, certain infections like rubella, cytomegalovirus, and lots of syndromes which we see in pediatrics could be associated with diabetes. So coming to type 1. Type 1 is a polygenic disease, and we know that it is because of the autoimmune mediated destruction of the beta cells. And how do we know that this is an autoimmune process? Because they have antibodies against specific antigens which are specific to the beta cells. The commonest one which is done is the GAD antibody, the other is IA2 and the zinc transporter. And the patients are insulinopenic. So once insulin is stopped because of whatever reason, these children are likely to develop ketoacidosis. So this is a typical presentation of a child with type 1 diabetes. But over the period of years, as the information and the knowledge is gathering, we have come to realize that there is a significant proportion of these type 1 children who don't have autoantibodies. That means none of the autoantibodies are present even at the time of diagnosis. We know that these autoantibodies can disappear over a period of time. GAD is the antibody which is persistent for a longer period of time. So as the duration of diabetes goes on, these children can become autoantibody negative. But there is a proportion of patients, about 15 to 20%, who can have no antibodies even at the time of diagnosis. And these children, the antibody negative children, when they are analyzed further, about 5 to 15 or 20% of them turn out to have a genetic cause or a monogenic cause for diabetes. And why is it important to know that? Does the child have a monogenic cause for diabetes? I will elaborate later. But just to say that it actually gives you a specific diagnosis for that child. Everyone wants to know that why did this happen to my child? So it gives you a diagnosis, and it has a lot of important implications for management and further prognosis and the evolution of the disease in that patient. So from our own experience, one of our students did this project with Dr. Bhatia, and in these 162 patients, right at the time of onset, that means within 3 months of diagnosis of diabetes, about 33 children out of this cohort, and this was a multicentric study with investigators from Delhi and BHU as well, that 33 children were negative for all the antibodies tested. And when these children had a further genetic analysis, it was seen that normally what we saw is type 1 diabetes, if you don't give insulin, they will usually will have ketoacidosis. So when they divided this group into children who were autoantibody negative and also did not have ketoacidosis, they turned out that 21 of that group of children, at least 6 of them, that means about 1/4 of them or 30% of them had a genetic cause for diabetes. So that is how it is important to understand that children who are autoantibody negative, who look like type 1 diabetes and who don't have ketoacidosis, we should start thinking that they could have some other cause rather than type 1 diabetes, because it has an important implication for management, as I'll elaborate in the next slides. So coming to few cases, illustrative cases, where I want to highlight that this was a 14-year-old girl coming from Jaunpur. She had a typical history of type 1 diabetes, sugars about more than 400, but no ketones at that time. And she was referred to us for management. On examination, there was nothing, no clue suggestive of anything, except that the child was managed, stabilized, since she had such high sugars. When we went to the detailed history, this is what is important. Her mother had diabetes. Her father, unfortunately, passed away in COVID. He also had diabetes, but look at the maternal history. The mother has diabetes, which was onset at 25. Her elder brother has onset of diabetes, which was at the age of 32. The mother's younger sister had diabetes at the age of 26. So all of them had diabetes, which was less than 30 years of age, managed with oral hypoglycemic agents. So this is not a common history which you would get in type 1 diabetes. Generally, type 1 diabetes, if the parent has diabetes, depending on which parent has diabetes, the risk of developing diabetes in that offspring is 1 to 7%. So this is not something which is common for a type 1 diabetes child. But still we went ahead and did her antibodies because she had such high sugars, typical of type 1. So we just wanted to rule out whether she has type 1 diabetes or not. So they were negative. And then since the antibodies were negative, such strong family history, we suspected that she could have maturity onset diabetes of the young. So an NGS panel was done. And lo and behold, she turned out to have an HNF4 alpha mutation, which is a known cause of maturity onset diabetes of the young. And then Sanger sequencing, this was all in Jayakrishnan's project, which he had done. He found out that the mother and the aunt also were heterozygous for the same mutation. And other members who had, her grandparents who had age of diabetes, older age of diabetes from the paternal side did not have that mutation. They were wild type. Here, one thing I would like to highlight is when you have maternal transmission of diabetes, although the mama also has, but if there's a maternal transmission of diabetes, the other important differential diagnosis becomes mitochondrial diabetes. Mitochondrial DNA has a maternal transmission. So the diabetes or the disease would be transmitted from the mother to the child. And it is associated with hearing loss. So if you have a young patient with diabetes and maternal transmission and hearing loss, you should strongly suspect for mitochondrial diabetes. In this, the commonly associated mutation in her was negative. So knowing that this girl had HNF4 alpha mutation, she was continued on glargine because initially she was on a basal bolus regimen as we would do in any type 1 diabetes child. But subsequently, she was started on tablet glycoside and a maximum dose of glycoside was given. And we could actually cut down on her bolus, just give her basal insulin with glargine, and the prandials were taken care of with OHA. She's very well controlled. Her A1Cs are 7 to 7.8% in the last 1 year. and continues to be only on basal glargine with glycoside. So the clinical characteristics when you should start suspecting MODY would be early onset diabetes, features which are not typical of type 1 diabetes. That means the child has autoantibody negative. There is endogenous insulin production, which we can find by doing a C-peptide level. In type 1 diabetes, you know there is a phase called as honeymoon phase. As soon as the diabetes is diagnosed, there is a period when the beta cells recover function or there's some endogenous insulin production, which we can detect by measuring C-peptide. The other way of doing is the urinary C-peptide to creatinine ratio. Both can be used to look at the endogenous insulin production. So if the child has endogenous insulin production, which we can know by knowing that the requirement of insulin is very small even beyond the honeymoon period. And there's lack of ketosis. Because of any reason, if insulin treatment is interrupted, these children do not develop ketosis. So these are the situations where you should think about MODY and get an NGS panel done. The only word of caution in doing an NGS panel for any kind of monogenic or any kind of a genetic disorder, I shouldn't even say diabetes, is that interpretation of the results requires expertise. What you would get from a med genome lab or a strand lab or a life cell lab would be likely pathogenic, variable of unknown significance. Over the period, even in MODY, people have realized that if you could see that these are the various genes which have been implicated in MODY, and some of them like PAX1 and these have actually been removed from the category of MODY, because over the years people have realized that the prevalence of the mutations which were first labeled to have caused MODY are prevalent in the common population also. So you cannot label them as pathogenic. So this kind of understanding and interpretation has come by people having knowledge about the what does the gene cause and what is the prevalence in the community, and can we label this mutation as pathogenic or not. So all kinds of genetic or NGS results actually should be interpreted by an expert, or at least we should take the help of an expert if we ourselves are unsure, before labeling it as likely pathogenic or attributing it to the cause of the disease. These are the most common subtypes of MODY which we will come across. There is about 16 or 18 different genes, but we should be aware of these common ones. The GCK or the glucose kinase gene mutations are seen mostly in elderly. So we as pediatricians or looking after adolescents, we are not so concerned about these because they have mild hyperglycemia and they come to attention. Usually if the woman gets pregnant, then their sugars are tested and that is the time when they come to attention. These are the three major ones which most of us should know because they present in the childhood or adolescence. And the important thing to remember is that many of them can be managed with sulfonylureas. The HNF1 beta, which has other renal and hepatic cysts and other complications, is the one which requires insulin. HNF4 alpha gradually over a period of time will require insulin subsequently, but the other two can be managed with sulfonylurea. And glucokinase gene mutation, since it has mild fasting hyperglycemia, usually does not require any treatment. So this was one type of diabetes which we should be, at least we should be aware of and should suspect as the case can be. Coming to the next case, this is a 4-year-old boy, first time presented in 2003 with deranged blood sugars, A1C of 8.6, and he was started on insulin, very irregular. Even up till now, he has had very irregular follow-ups. At the age of 10 years, he had bilateral hearing loss, and pure turn PTA showed bilateral sensory neural hearing loss, and subsequently the child was lost to follow-up. At the age of 16 years, he had vision loss, which was gradually increasing and had polyuria. So it was attributed probably that he has poor glycemic control. That is why he has polyuria. And this is diabetic retinopathy. This vision loss is diabetic retinopathy. But his A1C came out to be 7.6%. So his polyuria could not be explained because of uncontrolled blood sugars. Fundus examination showed probable optic atrophy. He was managed on basal bolus with hearing aid. His blood sugars had improved, but still his polyuria continued. So we did a water deprivation test and he turned out to have central diabetes insipidus. So the child who has diabetes, insulin requiring diabetes, diabetes insipidus, vision problem, sensory neural hearing loss, I'm sure all of you have guessed it. It was Wolfram syndrome. And the genetic testing did prove that he was a homozygous for VFS1 on exon 8, which was a likely pathogenic. So why do we want to know that Wolfram syndrome? One is that this vision loss is usually, most of the children with Wolfram, when they have this vision problem, which occurs later on in the course of the disease, they actually are labeled as diabetic retinopathy. And when it comes out that the blood sugars are better, when they show optic atrophy, when the fundus is examined, then we start thinking about that this could be not because of diabetes and this is something else. And it is important to know about Wolfram syndrome because other than having all these manifestations, the cause for Wolfram is because of the endoplasmic reticulum stress response. That is degenerative and it causes apoptosis and cellular death in not only in the pancreas, but in the neuronal tissue. And it's a degenerative disorder with insulin requiring diabetes. So usually the natural course of this disease is that children have diabetes earlier on in the first decade of life, then optic atrophy, diabetes insipidus develops later on, and over a period of time they can have sensory neural hearing loss. But the associated features are more debilitating and determine the life expectancy in these patients. So if this is diagnosed or we suspect of it and do an NGS or come to the diagnosis, at least we are aware of it. We evaluate for the associated bladder dysfunction. We can actually help them with avoid nephrotoxic drugs, avoid recurrent infections, and prevent the kidney damage which can occur because of undiagnosed recurrent infections. But the major debilitating condition is the neurological complications which occur because of the neurodegeneration. So in such situations, the prognosis, we have to give a guarded prognosis to the family. And the typical median age survival is up to the 4th decade of life. So careful clinical monitoring, supportive care are fundamental to relieve the debilitating symptoms and to manage so that we don't, those patients and the family are aware of what is going to come in the future and they are well prepared for it. So we have talked about MODY, we have talked about Wolfram syndrome, which are monogenic disorders of diabetes. This is a very uncommon cause, which was actually looked after by Dr. Bhatia. 12-year-old boy, diagnosed with type 1 diabetes at 5 years of age, well-controlled diabetes. And then 20 months later after the diagnosis, he developed proptosis. So complete evaluation for this child was done by MRI and biopsy, which showed a non-specific inflammatory mass. Later in the course of the disease, the child developed moderate to severe sensory neural hearing loss and he wears a hearing aid. He then had symptoms of recurrent pain in abdomen for which he was evaluated. And maybe he has associated exocrine pancreatic insufficiency. That is why fecal elastase was done to estimate whether he has exocrine pancreatic insufficiency or not. For these recurrent pain in abdomen, he had a CTA angiography which showed a small body and tail of pancreas, probably atrophic. So his investigations were done. He turned out to have GAD antibody positivity, but we couldn't explain all this, what was happening. So going to the various causes of autoimmune positive, but can he have an unusual monogenic type of diabetes, which is not type 1 diabetes, but has autoimmunity. So went through the list of various genes which could explain it. And then the result, this is just giving you an idea that how he was followed up with insulin and pancreatic enzyme replacement, immunomodulatory drugs for his proptosis because he had that inflammatory mass, and now he doesn't have proptosis, and hearing aids. So he had all this in his management. So the DNA was sent for genetic studies to Exeter, and he turned out to have mutation in SLC29A3 gene, which is the syndrome H, or it is a histiocytosis lymphadenopathy plus syndrome, where they have lots of cutaneous features, hepatosplenomegaly, and they have one component is insulin-dependent diabetes mellitus. So this is how, just knowing the evolution of the course of the disease, investigating or actually reading into that what could be autoantibody positive monogenic type of diabetes, the actual diagnosis was made in this child. So certain monogenic disorders are associated with wide range of autoimmune clinical manifestations, which are not generally reported in type 1 diabetes. So such conditions, they should urge you to actually search the literature and read more about it to reach to a particular diagnosis. After having seen these genetic diagnoses, coming to a different category of diabetes, this is a 15-year-old girl who presented recently to our clinic with history of polyuria and diagnosed with diabetes for last 1 year, but was on oral hypoglycemic agents for this whole period of time. Never developed ketosis. Her sugars were always 250 to 350 range. No history of autoimmune, any other autoimmune disease in her or in the family. No history of diabetes in the family. Very lean and thinly built girl. Her A1C was 16%. So as is our norm, that all children, we do test for GAD antibody because that's the cheapest actually. We should do all three. But since it's the cheapest and a poor affording family, we at least do GAD antibody. And that, as I said earlier, that antibody persists for a long period of time. She already had been diagnosed with diabetes for 1 year. And her other antibody was also negative because since she was so lean and did not gain weight, probably it was because of the uncontrolled blood sugars. So always in patients who don't fit into typically a type 1 diabetes and who have a young onset, we do tend to do ultrasound abdomen to look for pancreatic calcification. That do they have chronic calcific pancreatitis or calcific pancreatitis, because of which they have developed diabetes. I don't have an ultrasound picture, but this is her X-ray which showed, you can see transverse, the arrow is pointing towards the transverse calcification where the pancreas is. So this is how a calcific pancreatitis X-ray would look. And we evaluated her subsequently with stool fat, which showed more than 15 droplets. And she was put on pancreatic enzyme replacement and insulin. So this is a case of diabetes secondary to calcific pancreatitis. And age is no bar. We see children 10, 11, 15, all age groups. And that is why ultrasound pancreas, and now subsequently I will show the next patient, that if the ultrasound doesn't show, we should even consider doing a CT pancreas, which will give you more information. So this is a 20-year-old who presented typically with features suggestive of type 1 diabetes and did have ketones once when she had high blood sugars, but she had recurrent pain in abdomen. After that, the urine ketones were negative, so that pain in abdomen was not related to DKA. At least that much we know. And she was on insulin, but since she had recurrent abdominal pain and had lost weight in the last 6 months, about 10 to 12 kilos. And she had poor appetite since September 20, and she presented to us in the January of 2021. And this girl had a very strong family history of type 2 diabetes from the maternal side. So we did a mitochondrial gene because that is available in our institute. That was negative. She didn't have sensory neural hearing loss as well. And as I said earlier, we did an ultrasound abdomen, which did not reveal any abnormality, no calcification. But since she continued to have this pain in abdomen, we went ahead and did a CT. So in this girl, the differential would be type 1 because she has shown ketosis once, but against type 1 would be no antibody, strong family history. MODY, probably strong. This could still be a MODY. Mitochondrial diabetes, there was no deafness, and the mitochondrial DNA mutation came out to be negative, the commonest variety. So the only possibility we could think was of MODY or pancreatic diabetes. But since she had this pain in abdomen, we went ahead and did a CT. So this arrow which you can see is pointing to the head of the pancreas which she has. And what you should normally have is, this is the normal ultrasound on the left side. So after you have head of the pancreas, the body and the tail should be visible, right? But if we go back to our patient, you can see the head and then you can see only the intestines. There is no tail and body of the pancreas. So this girl has dorsal pancreatic agenesis with insulin requiring diabetes. And PDX is a gene known for causing, and there are 2 or 3 more types of MODYs which can be associated with pancreatic agenesis or dorsal pancreatic agenesis. Her NGS is still awaited because she couldn't afford, and now we have sent her NGS, which we are waiting for the report. So coming to, after all this, we have seen that there is a group of patients who are unlikely to be type 1 diabetes. And this is a long list which I have spoken about earlier, but it cannot be emphasized. Even if I speak it out 4 times, still it is not emphasis of these points, which we should always remember. I've kept the last as type 2 diabetes. We should never forget type 2 diabetes. With the increasing prevalence of obesity, our lifestyle, sedentary lifestyle, our food habits, all of the time we are stuck on our mobiles, no physical activity. As the prevalence of obesity is increasing, we are bound to see more and more type 2 diabetes in children and adolescents as well. This was just a 14-year-old boy who presented with polys, had very high blood sugars, ketones were positive, but had a high BMI with acanthosis. Antibodies were negative. Over the period of time, his requirement of insulin really petered to 0.1, 0.2 units per kg. So we were able to stop his insulin. We did a C-peptide, which is detectable, and now he's fairly well controlled on metformin, 1 gram twice a day. So we should actually be reminded about this obesity epidemic and the type 2 diabetes prevalence going up in our country. Management of these children would be like any other diabetes in the adult with lifestyle modifications. The oral agents which we normally use are metformin, and now GLP-1 analogs are also approved to be used in children. So oral semaglutide is a good drug to be used, which is 3 milligram per day. The only problem is, other than the cost, is it leads to actually significant nausea and vomiting. So you just have to tide over that period initially, that the child for the initial 1 to 2 weeks, and after that they get used to this and don't have that much of nausea and vomiting. So that 3 milligram daily dose is a good dose to be used in children. The targets for control are the same as in type 1. The important thing to remember is that as the age of onset of diabetes goes down, there are large studies done in Australia, Denmark, where they have shown that every decade decrease in onset or the decrease in the diagnosis of diabetes increases the mortality. So younger the age of onset of diabetes, we really have to be careful. All comorbidities have to be assessed at the presentation and they have to be checked annually. And the prevalence of or the occurrence of complications related to diabetes are higher in type 2s as compared to type 1. There's a big study called as the SURGE study in the US, where they have a group of type 1 and type 2s. And all complications, nephropathy, retinopathy, the prevalence is higher in type 2s as compared to type 1. We thought that type 1 occurring at an earlier age, the management is so difficult, but no, the complications occur higher and the life expectancy decreases as the age of onset of diabetes decreases. So we really have to be very vigilant about type 2 diabetes. And probably in our country, we should have screening program. These are the ISPAT guidelines for screening for type 2 diabetes, where they say that targeted screening should be done or can be considered after onset of puberty or 10 years of age, at least in children who are obese and have risk factors for type 2 diabetes. That means they have a family history of diabetes, early CAD, cardiometabolic risk factors. They should be screened for type 2 diabetes. And if the tests are normal, the screening should be at least done at a minimum of 3 years interval. But if the other risk factors increase, we should do it annually. And all of them should be assessed for the associated comorbidities. Just one word about OSA or the obstructive sleep apnea. Actually, it is a very good indicator of cardiac mortality. In all conditions of insulin resistance, OSA correlates to cardiac mortality. So we should assess children who are obese for OSA and to have preventive measures to improve their cardiometabolic health. So to conclude, I would like to say that not all children with diabetes have type 1. I think I've put my case forward for all of you to consider that not all children with diabetes have type 1. A careful history, examination, investigations, and evolution on follow-up reveals or makes us suspect that it is not type 1 and a different etiology should be looked into. Genetic screening is valuable, but as I said, caution is that interpretation requires expertise. And it is important to establish an etiology because the family wants to know what caused the diabetes. And other than that, appropriate treatment, because you can start sulfonylureas in lots of neonatal diabetes and MODY. I've not touched into neonatal diabetes because it's a complicated and a separate topic. You can actually evaluate for associated comorbidities as we saw in Wolfram syndrome, and the prognosis and appropriate management for involvement of exocrine pancreas, because otherwise it will lead to malnutrition and deficiency of important nutrients. Thank you.
Preeti, that was an amazing presentation. Diabetes treat karna was quite difficult. And now when we have a patient, we'll have to think, oh my God, is it the real diabetes that we knew or is it something special?
I think Arpita had given me just to confuse you.
I know. So thank you very much for opening our eyes on that. Thank you, Preeti. I think the student is as good for nearing the teacher.
She's too high for me to reach.
Very well done.
Thank you, ma'am. I will now request Malakumar ma'am to present a memento to Preeti ma'am. We will now break for lunch and assemble here again in half an hour. Thank you.
2:30. It's like session will resume. And the faculty is invited.
Good afternoon, everybody. So it's my privilege to introduce our next speaker, Professor Vandana Jain, ma'am. Ma'am is a professor in the Department of Paediatrics at All India Institute of Medical Sciences, New Delhi, and she is the in charge of the Paediatric Endocrinology division there and coordinator of the DM program in Paediatric Endocrinology. Ma'am has done her fellowship in pediatric medical education and a fellowship in pediatric endocrinology. Her chief areas of interest are infancy, growth, and diabetes and non-alcoholic fatty liver diseases. She has completed more than 20 funded research projects as principal investigator and has more than 100 peer-reviewed publications. I would invite ma'am to deliver her talk on precocious puberty.
So, very good afternoon, everybody. And first of all, I'd like to thank the organizers for inviting me to this meeting. So, I'll be talking about precocious puberty. Okay. And this is how we'll go about it. First, I'll just present one or two case scenarios to get you into the frame of mind of discussion of puberty. Then physiology of puberty, etiology of precocious puberty, approach with some examples, and then management. So let's go to the first case. A 3-year-old girl is brought to you with concern of rapid breast enlargement noted for the last 6 months. There is no pubic or axillary hair growth. She hasn't attained menarche. And she also has mild developmental delay. She is only 3 years old. So what comes to your mind? So you would probably want to know more, something's more in the history and something's more in the examination. So can one of you just point out what are the important things you want to know in history in such a case? And an examination? Okay, so just keep thinking about these questions and we'll come to it later. Okay, then another case, 8-year-old healthy girl. She has come to you because her SMR is B3. You note that her height is at the 90th centile, weight is also at around 75th to 90th centile, and her mid-parental height is only at the 25th centile. Now, her parents' concerns are, is this normal? Or are any tests needed? When will she attain menarche? Will there be adequate height gain? And what would be her final height? Will she remain short? And is any treatment needed? So this is another scenario which we commonly face. So hopefully at the end of the presentation, we should be able to answer these questions and many more. So coming to the physiology of puberty, So this slide shows the hypothalamic pituitary gonadal axis. And basically, if you look at the x-axis, we see the fetal period, infancy, childhood, and puberty and adult. Okay. So this side, the blue one is the males, and for yellow is the female HPG axis. You have FSH, LH, and estradiol. So in fetal period, there is an increase in FSH, LH, and consequently the sex steroids. But then at birth, all of these are at very low levels. Then again, in infancy, there is a mini puberty. So again, you have a rise in FSH, LH, and testosterone in males, a slightly smaller rise in estradiol in females. And what is the importance? Can anybody tell me what is the importance of this rise in testosterone in infancy in males? So it is important for further increase in penile length or descent of testes. And in girls, sometimes you see that they may have slight breast development or slight discharge. So that can be because of this. After this, the HPG axis becomes quiescent. And then in puberty, there is a rise, gradual rise, and then you reach the adult levels. So what influences pubertal timing? So the most important thing is the biological clock. So because what tells the hypothalamic neurons, GnRH secreting neurons to start their pulsatile secretions is that the biological clock is there, and this is actually not as much determined by chronological age as by the bone age or the skeletal maturity of the person. So often we see that somebody who is very malnourished, who would have a delayed bone age because of malnutrition, they may enter into puberty late. On the other hand, especially in females, we see that if they are overweight or obese with a slightly advanced bone age, they may enter into puberty earlier. For example, in the case 2 that I showed, the child who has something like a constitutional acceleration of growth. So she may enter into puberty earlier. We are all familiar with constitutional delay of growth in puberty, but there is a constitutional acceleration also, which is more often seen in girls. So here we see the various factors, and we see that the most stress is on nutrition, body mass, body fat, and so on. So what are the actual pathways? So if you look here, this is the GnRH neuron, and the major gatekeepers of this neuron, like which tell it to start secreting GnRH, are the kisspeptin and the kisspeptin receptor. So we see the kisspeptin neuron here, and there is another KNDY neuron. KNDY stands for kisspeptin, neurokinin B, and dynorphin. So all these three together, KNDY neuron, so they have a positive influence. On the other hand, we have MKRN3. This is now identified as another important gatekeeper. This has a constitutively inhibitory influence on KNDY and kisspeptin. So we'll come to it later that actually now it has been seen that if somebody has a loss of function mutation in MKRN3, that person will lose this negative inhibition and will enter into puberty earlier. So it is one of the causes of precocious puberty. And this kisspeptin, can somebody tell me why is it called kisspeptin? There's an interesting story. Yes. So because it was discovered in a lab in Hershey, which is famous for Hershey's Kisses. So that's why it's called kisspeptin. Tanner staging in girls, this is how puberty progresses. We are all familiar with it. We have to do the Tanner staging based on breast development and pubic hair development. Typically, we use only the breast development. So 1 is prepubertal. There is no stage 0. 1 is prepubertal. 5 is when you attain the adult contour. And typically, menarche occurs in stage 4 or late stage 3. And growth spurt occurs in stage 2 and 3 in girls. Also, of course, concomitantly, the internal organs are also increasing in size. So if you do an ultrasound, you'll find that ovarian volume in younger children, prepubertal children, is somewhere around 0.3 to 0.9. And it's more than 1 cc in pubertal. Mean post-pubertal volume in Tanner stage 4, 5 will be around 4 cc. In boys, Tanner staging is done by looking at the genitalia. And the first stage of puberty is when the testicular volume increases to 4 ml. So 1 to 3 ml is prepubertal, 4 ml is pubertal, and then of course the adult volume is 25 ml, 20 to 25 ml, and this can be measured using this orchidometer. Growth spurt in boys occurs towards stage 4. What is normal, precocious and delayed puberty? In girls, normal is thelarchy between 8 to 13 years. Precocious is when thelarchy is before 8 years or menarche before 9.5 years. So either of these is precocious puberty. Delayed is when no thelarchy by 13 years or no menses by 15 years or no menarche 4 to 5 years after pubertal onset. For boys, normal onset is at 9 to 14 years. Precocious is increase in testicular volume seen before 9 years or basically secondary sexual characters developing before 9 years. And lack of testicular enlargement by 14 years is delayed. So coming to the main topic, that is precocious puberty. So it is primarily of two types. Either it is central, where the whole hypothalamic pituitary gonadal axis itself becomes active at an earlier age. It's also known as central or true. And the other one is independent. So the HPG axis is still quiescent, but still the steroids are coming from somewhere. So they would typically come from either gonads or adrenals or from exogenous sources. So they are called peripheral. Estimated incidence of precocious puberty in girls is about 1 in 5,000 to 10,000. And in boys, it's about 1/20th of that of girls. So it's much less commoner in boys. And in girls, more than 90% of the cases are due to central precocity, whereas in boys, it is roughly equal. Both central and peripheral contribute to 50% each. What are our chief concerns? Why are we worried? The first and foremost concern is that it could be pointing towards something sinister. We should not just look at puberty as, okay, puberty has started, we need to do something about it. We need to find the etiology. So again, Dr. Preeti was also highlighting the importance of finding the etiology in any condition that we see. Same is true with puberty. So it could be a marker of something sinister, maybe a CNS malignancy or tumor. Or it could be a CAH or an uncontrolled, untreated hypothyroidism. So all of these things we have to keep in mind. That is the most important thing. Then of course, tall stature in childhood. So the child would look tall, more mature in childhood and may end up having short final height. Early menarche in girls may be a concern. So coming to etiology. So etiology, we'll first discuss the central precocious puberty and discuss it commonly for boys and girls. So it can be because of CNS lesions, which could be congenital. Most important one that we should all remember is hypothalamic hematoma. Apart from that, hydrocephalus due to any cause, arachnoid cyst, myelomeningocele, septo-optic dysplasia, neurofibromatosis type 1, tuberous sclerosis. These are all important causes. Acquired lesions, we have inflammatory conditions, granuloma, trauma, surgery, radiation, chemotherapy. So remember that after radiation for any either CNS malignancy or because of ALL or some other reason, typically GnRH deficiency is uncommon. You more commonly have precocity. Then tumors, including pineal tumors, optic gliomas, craniopharyngiomas, and so on. Without CNS lesions, it can be, most important is probably prolonged, untreated, peripheral precocious puberty. Why does it go on to develop into central? Because of advancement in bone age. So as I said, bone age determines your biological clock. Then mutations, as I showed you, there are the KIS1 and KIS1 receptor genes. So if there is gain of function in that or loss of function in NKRN3. Although these are till now, very few cases have been described, but now people are looking more and more into the genetic etiology of precocity. International adoption, endocrine disruptors, one thing, lavender, for example, lavender-based products we have seen clinically also. Sometimes these can lead to precocious thelarchy. Phytoestrogens like soy products. We had a family where two girls both developed precocity because they were having Nutrilla daily. That's what the mother said. And once we asked her and she stopped, then the breast development actually regressed. IUGR and some syndromes. Then idiopathic, probably the most important, especially when we talk about females, girls, and especially if age is more than 6 years, most of them turn out to have idiopathic central precocious puberty. Then coming to peripheral precocious puberty, in girls, you have isosexual conditions, most important being ovarian causes like benign follicular cysts of ovaries or McCune-Albright syndrome and ovarian tumors which secrete estrogen like granulosa theca cell tumors. Then exogenous administration, and one causes primary hypothyroidism. How does primary hypothyroidism lead to precocity? Anybody? Anybody? Yes, very good. And do you know the name of the syndrome? Sometimes they develop a syndrome. Van Wyck-Krumbach. Yes, very good. So that is another important cause. Then heterosexual, basically when you develop more of virilizing features such as virilizing CAH and virilizing ovarian or adrenal neoplasia. When we talk about boys, peripheral precocity in them, the most important cause is adrenal cause, CAH. CAH is the most important cause. It could be because of 21 or 11 hydroxylase deficiency. Then tumors like virilizing adenoma or carcinoma. Amongst the testicular causes and important causes, testotoxicosis. What is testotoxicosis? There is an activating mutation of the LHCGR, basically the LHCG receptor. So even without LH, the testes behave as if they are being stimulated by LH. And so they start producing testosterone. So it is familial, it is autosomal dominantly inherited, but it is male limited. So even if the mother is the carrier, she will not have any features, but her sons will develop it. And then Leydig cell tumors of the testis. HCG secreting tumors. So for example, choriocarcinoma, hepatoblastoma, germinoma, and exogenous administration. And heterosexual condition would be very rare, but exogenous estrogen or feminizing adrenocortical tumor. Okay, so how do we basically differentiate between central and peripheral? The most important thing is that in CPP, in central, the pubertal course parallels that of the normal development. Like we know, hierarchy first in girls, then about SMR late 3 or early SMR 4, you would have menarche. Growth spurt will be somewhere between stage 2 and 3. So there is a concordant increase in all the pubertal development. Similarly, in boys, first the testis will start increasing and then the child will start developing pubic hair or increase in SPM. So in peripheral precocious puberty, this concordance is lost. There may be a very discordant development. Child may first start having menstruation, even at SMR 2 or 3. What is the importance of bone age? Does it distinguish between central and peripheral? It does not distinguish too much because ultimately bone age is advanced because, as we know, it is the estrogens which act on the bone. So whether they are coming because of HPG axis activation or directly. So there is an exception that in which case of precocious puberty you will have that the bone age is not advanced. Hypothyroidism, right? So important thing is that typically in central precocious puberty, bone age actually corroborates with the normal bone age at which development occurs. And now there are several studies to show that typically SMR 2 to 3, breast 2 to 3 stage comes at around 10.5 to 11 years of age. And menarche typically occurs at a bone age of 12.5 years. So even if a young child who is overweight, she has a bone age of 12.5, she can develop menarche. Okay, so quick break into some spot diagnosis of using some clinical photographs. Okay, I would like the residents to answer. Okay, this is a 6-year-old child. You can see the masculine appearance. His weight and height were both more than 95th centile. He had few cafe au lait spots. They are small cafe au lait spots. Okay, and when the genitalia was examined, it was G3. Pubic hair also stage 3, testicular volume bilateral 12 ml. So what do you think it is? Is it central or peripheral? Does the child seem to have central or peripheral precocious puberty? Testicular volume is bilateral 12 ml, which you would typically see in stage 3. And pubic hair is also 3. So there is a concordant kind of development. So looks like central. So can you think of any cause of central in which you can have small cafe au lait spots? Neurofibromatosis type 1. What are the differentials for cafe au lait spots? Hardly any, no? So when you see small ones there. So this child turned out to have neurofibromatosis type 1. In any case, you would do an MRI in children with central precocity. Okay, again a spot diagnosis. 7-year-old girl with hierarchy, height of 103 centimeters, which was at -4 ST. And bone age was 4 to 5 years. And you can see the child. Yes, so this is hypothyroidism, primary hypothyroidism. A 2.5-year-old boy with gynecomastia, bony deformity. You can look at the bony deformity here in this limb. And he has also Caffioli spots. McCune Albright mein, why would a boy have gynecomastia? So this is a bit difficult. This child actually had pseudo-gynecomastia. This child also had neurofibromatosis. And these were pseudo-gynecomastia. These were not actually breast tissue, but the NF1 lesions. Okay, a 2.5-year-old boy with pubic hair noted for the last 5 months. He was tall and well developed for age. Testicular volume was 2 ml bilateral. And you can see the SPL, which is very well developed. The penile length is quite increased and he has pubic hair. What is this likely to be? Likely to be peripheral or central? Peripheral. So most common cause? CAH. So he seems to be hyperpigmented also, although they may not always be, but CAH should be ruled out first. Simple virilizing, CAH. We know CAH has simple virilizing and salt wasting forms. A salt wasting form would come to light because of adrenal crisis. But simple virilizers may go undetected and then they present to you like this. A 1.5-year-old girl with pubic hair noted for the last 2 months. Chubby, facial hair was also present, acne was also present. Her BP was 110/76, which we can appreciate it is high for her age. What do you think she has? CAH could be one possibility, but more likely, yes, she has Cushingoid features. Why should a CAH child be Cushingoid, right? CAH child would be rather have failure to thrive. So, cause would be most likely androgen secreting tumor, adrenal tumor. So, ACC, adrenocortical carcinoma is the most likely cause. Okay. So, okay, coming back to the presentation. So, normal variants, we have discussed precocious puberty, then we have normal variants. So, premature thelarchy. What is premature thelarchy? When you don't have other features like advancement of bone age, or when you look at the ultrasound and the uterus and ovaries are still prepubertal, but the child has breast development. If you do a GnRHA stimulation, which we'll come to later, then this child would have FSH predominant response. And if the onset is before 2 to 3 years of age, then mostly it regresses on its own. So sometimes you see small children presenting with breast development, 1.5 to 2-year-old girls. It typically regresses on its own. Of course, you do need to do a bone age. You do need to do an ultrasound to see that the uterus and ovaries are prepubertal. Bone age is not advanced. The child's growth spurt would not have been there. So her height would be appropriate for her age. So in that case, you'll think of premature thelarchy. What is premature pubarchy? Pubarchy means when you have pubic or axillary hair coming before the age of 8 years in girls or 9 years in boys. A similar term is adrenarchy, but adrenarchy means that there is biochemical increase. So you have DHEAS, which is increasing. And again, typically it occurs at 8 years in girls and 9 years in boys. So DHEAS more than 40 is the indicator. So pubarchy, premature adrenarchy itself is not of any major consequence. You don't have to worry. Only thing is when you see such a patient, you have to rule out any features of systemic androgen excess. What would be the features of systemic androgen excess? Increase in growth rate or acne, or in girls, virilization. So if you see these features, marked growth acceleration, bone age advancement more than 2 standard deviation, clitoral or phallic enlargement, or excessive acne, then you have to think of either non-classical CAH or adrenal tumors. So don't think that, okay, this is just benign pubarchy. Also, it has been seen that in many girls, especially when they follow this sort of course, that they are born with a slightly lower birth weight, then they have accelerated catch-up, they become overweight. Many of them develop premature puberty. You will see many parents bringing their young girls, 6, 7 years old, with acne or with axillary hair, body odor, which are features that you would normally expect after 8 to 9 years. And then these children may go on to develop PCOD. So this course is known. So if you see this kind of a pattern, then you have to advise the family regarding diet and lifestyle, because there is a risk of insulin resistance developing. Coming to the diagnostic approach. So in history and examination, we have already, I think, understood that we need to look at the chronology of the appearance of the various secondary sexual characters, rate of their progression, growth spurt, whether it is present or absent. We have to look for neurological features because it could indicate a CNS tumor or a space-occupying lesion, exogenous steroid exposure, past history, for example, radiation, encephalitis like tubercular encephalitis, family history. In examination, Tanner staging, genitalia examination, height, weight, BMI, and body proportions. Look for features of hypothyroidism. Look for neurological, neurocutaneous manifestations. Do a good neurological examination. Look at the BP. Why? Why do you want to look at the BP? In some cases of virilizing CAH, you may have hypertensive forms like 11-hydroxylase, for example. Okay, interpretation of testicular volume in boys with precocious puberty. If you see a boy brought to you with concern of precocious puberty, that would mean that he has increase in penile length or pubic hair. But if both the testes are less than 4 ml, what is this likely to be? Probably it is peripheral, and most likely CAH is the number one cause. So think of that, or exogenous. If both the testes are also enlarged, what do you think of? Central, or you think of familial testotoxicosis. I told you earlier, it is an activating mutation of the LH receptor. So again, both the testes will increase in size. Or it could be HCG secreting tumor. So if HCG acts like LH. Okay, so if there is a tumor like a germinoma somewhere, it can secrete HCG. It is not central puberty, but the testis will be enlarged. So, but remember that testis enlargement does not exceed Tanner 3 in testotoxicosis or in HCG secreting tumors. If testicular volume is more than 12 to 15 ml, then you have to always think of central precocious puberty only. What about asymmetric testicular enlargement? You see one testis big and the other one small. What is it? Testicular tumor, most important, or it can be McCune-Albright syndrome. In McCune-Albright syndrome, typically we see a laterality. The skin manifestations are also sometimes more common on one side. If it is a girl, she may have more prominent breast or bigger ovarian cyst on one side. Boys can have one-sided testicular involvement and so on. So, okay, after the history examination, you come to investigations. So bone age, we've already discussed. This is an important investigation. It tells you how much the skeletal maturity has advanced. It also gives you an estimate of the final height, which is sometimes a very, very important question for the parents. And ultrasound will again tell you whether the internal organs, especially in girls with precocious puberty, are they also increasing in size, uterus and ovaries, or are they not? So it helps you in distinguishing between thelarchy, just premature thelarchy, versus premature puberty. Also, ultrasound of ovaries will help you in finding out if there are ovarian cysts, or which could be there in benign follicular cysts, McCune-Albright syndrome, Van Wyck-Grumbeck syndrome. All of these will have ovarian cysts, which are just secreting a lot of estrogens, or an ovarian tumor. Again, an ultrasound of testis or adrenals will also help you in revealing presence of any tumor. These are the average sizes. Based on ultrasound pelvis, how do you interpret whether the child has a prepubertal uterus and ovary or whether it is pubertal? So just look at this, 8 to 9 years when puberty typically starts, ovarian volume is around 1.2 cc. Prior to that, ovarian volume is very, very small. Many times they may be missed on the ultrasound. And similarly, uterus, so around 3.2 or so. You see at 8 to 9, 12 to 13, 3 cc ovary and 5.5 centimeter uterus. So this you can remember. Lab investigations, LH is very, very important. LH more than 0.3 has nearly 100% specificity for central precocious puberty. FSH levels are not very useful. Estradiol, prepubertal children typically have less than 10 picogram per ml. Similarly, testosterone, you can remember less than 10 nanogram per DL for prepubertal. And the elevation in central precocious puberty, the estradiol and testosterone are not very much elevated. They would be in range with the child's testis size or the child's breast size in girls. Whereas in peripheral precocious puberty, you can have very highly elevated levels. Highly elevated estradiol or testosterone with suppressed FSH-LH. So that would be indicative of precocious, peripheral precocious puberty. Other tests you can do as needed, like thyroid or 17-OHP or DHEAS. Then coming to GnRHA stimulation test. So what is this? This is a dynamic test. When suppose you are suspecting central precocious puberty, but your LH levels are somewhere around 0.1, 0.2. We know that it can happen because LH has a pulsatility. So when you measure, it may not be in the pubertal range. So you do a agonist testing, and then you give this injection and you test, you check for FSH and LH levels after 3 to 4 hours after giving the agonist. And in central precocious puberty, peak LH is generally more than 5 to 8 units per liter. And LH to FSH ratio is more than 0.6. MRI, what is the role? So definitely should be done in all boys with central precocious puberty. In girls, you can avoid in girls more than 6 years of age, because 6 to 8 years, you see many girls, especially if they are overweight, they are constitutionally accelerated, and hardly ever you will find any organic cause. So if there is nothing, no indication for that, you can leave it. But children below 6 years, girls below 6 years, you have to do. Boys, you have to always do. In children with central precocious puberty less than 4 years of age, even if the initial MRI is normal, it should be repeated periodically. Coming back to the first case that I showed you, that the 3-year-old child with bilateral breast development for the last 6 months, with no pubic or axillary hair, no menarche. Okay, child has mild developmental delay. So now what else do you want to know in history? Now does anybody want to tell me? What do you want to know in history? You want to know if she has anything to suggest, any CNS features, any family history. Has she had a growth spurt also? So all these things you want to know. And in examination, you definitely want to look at the SMR. You want to look for neurological features because she already has developmental delay. And okay, so in this child, you found that she had history of decristic seizures. You have heard of gelastic seizures? They are laughing seizures. Decristic is crying seizures. So they can both occur in hypothalamic hematoma. So child is sitting and then suddenly unnecessarily she's whining or crying, and then she becomes normal after some time. So that kind of history was there. And because she was very small, we could not find any other definitive history of vision problem or headache. On examination, her height and weight were more than 2 standard deviation. BP was normal, no neurocutaneous stigmata. Investigation, her bone age was 9 to 10 years. LH was 4.5, FSH 3.5. So they are both clearly in the pubertal range. Estradiol of 25 picogram per ml. So what do you do next? MRI, right? So you do an MRI, and this child was found to have an hypothalamic hematoma. How do you manage? Typically, surgery is not done when the child only has endocrine problems or the seizures are not too bad. If the child has multifocal or GTCS or which are poorly controlled drug refractory epilepsy, then surgery may be done. Otherwise, typically only for endocrine manifestations not done. Or if you have a very pedunculated kind of clearly surgically manageable hypothalamic hematoma, then you can go in for it. Otherwise, you manage with GnRH agonists. Okay. Another case, let me show you. 5-year-old child with increased growth. He also has pubic hair and increased size of genitalia for the last 2 years. Voice change and facial hair for 1 year. Weight is 23 kilos, height is 128 centimeters. Pubic hair is stage 4, SPL of 8 centimeters. Testicular volume 4 ml bilateral. So now my question is this central or peripheral precocity? Central or peripheral? You have testicular volume of 4 ml, but the pubic hair is stage 4. SPL is also 8. So it seems to be discordant. So this is more likely to be peripheral. But then you have testicular volume which is increasing. In this child, you did an LH and FSH, they were prepubertal. But then post GnRHA, LH was 5.5. Okay? And bone age was advanced. You can see the bone age as this triangle here. So this is the child's height and this is the bone age. Bone age was about 11 to 12 years. So this is secondary central precocious puberty in a child with CAH. Okay? So this can happen. And now the treatment would be as central precocity. Arpita, how much time do I have left? Sorry. How much? 5 minutes? Okay. Case 4, 5.5-year-old girl presented with pain and deformity of left leg and limping gait for the last 4 months. She also gives a history of 2 episodes of vaginal bleeding in the last 1 year. On examination, her height was 102 centimeters, which was in fact just below the 3rd centile. She had thilarchy, left B3, right B2, no pubic hair, coxa vara genu valgus deformity, multiple irregular large café spots. So first question, is this central or peripheral? Likely to be what? You see that she has vaginal bleeding, so she has attained menarche. But her breast development is not that much. Right side is only B2, left is B3. So this is likely to be peripheral. And you have large café spots. So what does it point to? So this is the clinical picture. You can see the large irregular café spots. And this is the bone. So she had polyostotic fibrous dysplasia and peripheral precocity. Her LH was low, estradiol was high, ovary showed follicular cysts. So this was, she also had hypophosphatemic rickets. Thyroid function was also done, it was normal. Why was thyroid function done? Because hyperthyroidism is also sometimes seen in these patients. And remember, not everybody would have such big café spots. Many times they may have just a very small one. So do that examination carefully. So this child turned out to have McCune-Albright. So how do you manage? If it is peripheral precocity, what can you give? Either estrogen receptor blocker or aromatase inhibitor. Okay. McCune-Albright is a very interesting syndrome, and there is a post-zygotic. That means it's a somatic mutation, not a germline mutation. Post-zygotic activating mutation in GNAS1, which encodes the GS protein alpha subunit. So you know that lot of hormones act through the GPCRs, the G protein coupled receptors. So a lot of hormones act through that. So TSH, GHRH, ACTH. So many of these patients have very variable kind of manifestations. But the common triad is the café spots, bony abnormalities, and precocious puberty, peripheral precocious puberty. Another case, a 6-year-old boy with complaints of acne, deepening of voice, height gain, genital enlargement over the last 1.5 years. And in this child, the important thing is this. On genital examination, he had pubic hair stage 5, left testis was 25 ml, right testis was 5 ml. So initially, the resident who saw it just looked at one testis and said, okay, this is central. So we did not look at the other testis. There's too much of pubic hair also. Sometimes we don't feel like palpating both the testis. And so the investigations were in that line initially. Bone age was advanced. LH was 0.8, which is actually suggestive of central. FSH was low. Testosterone was very high. So again, this provides a clue that this is not central. Because you have LH, which is suggestive of early puberty. LH is just beginning to rise. But you have testosterone, which is so high. So this child actually had a testicular tumor. That is why you had asymmetrical enlargement. He turned out to have a testicular tumor. Okay. This I will leave. Just to show you, actually, these two siblings had presented to us. When the elder sibling, you look at the face, he looks like a mature person, but he was only 11 years. And this younger one was 4 years. Both had hyperpigmentation, acne. In the first presentation, both were found to be hypertensive. And they turned out to have 11 beta hydroxylase. But the older child was already, his bones had fused. So his final height remained to be only 130 centimeters. For the younger child, he required, of course, both were treated with glucocorticoids, but the younger child was also treated with GnRH agonists for the central precocity. So I think I can leave the approach because we already discussed. So coming back to the case 2 that I had shown you first. The healthy 8-year-old who had height and weight both at around 90th to 95th centile. So what do you want to do with this child now? Do you want to treat or do you not want to treat? Further investigations actually showed that thilarchy was noted around 9 months back. She was slowly progressing into puberty. She has gained about 8 centimeters in the last 1 year. Pubic hair is stage 2. Her LH was 1.2. Estradiol was 25. Bone age was 11 years. So at 8 years, her bone age was 11 years. And predicted adult height. We can do some prediction using the bone age and the bone age and the current height. So that showed that the predicted adult height is 153. Would you like to treat this child? So when to use GnRH agonists? You have to take a decision, especially for children who are older than girls, 6 to 8 years, many people now feel that there may be, especially in view of the overweight and obesity pandemic, many children develop thilarchy, but usually it is a slow growing, sort of slowly progressive puberty. And although the bone age is advanced, which would be expected in any overweight child, when you do a bone age in any overweight child, typically they would have mild advancement of the bone age. But if the predicted adult height is coming in the normal range, so as I told you, this could be constitutional acceleration. They grow faster, but then they plateau earlier. They plateau earlier so that they finally reach their mid-parental height. So this, in that case, typically it is not very beneficial to treat with GnRH agonists, although you can have individualized kind of approach. Below 6 years, typically we want to treat because that has an improvement in the height prognosis. And sometimes because of psychological issues, if we feel that menarche is going to occur very early and the child cannot handle it, then we may do it. So various preparations are available for GnRH analogs. In India, commonly we have leuprolide and triptorelin. And triptorelin, especially in girls who are heavier, more than 25 kg, then 3.75 mg of leuprolide frequently becomes inadequate. Triptorelin is more potent, so you can use that. Or these are the 4 weekly preparations. Apart from that, 12 weekly preparations are available, 11.25 mg. And with that, the LH suppression is many times not adequate, but still clinical response is adequate. So with the first injection, some girls may have bleeds, menstrual bleed, which is because of transient increase in LH, FSH and estradiol. Transient, and then it goes down, so it can cause a bleeding, but you can just counsel for that. For follow-up, you do a height, velocity and Tanner staging. GnRH agonist test means that after giving the GnRH injection, if you do an LH after 1 hour, it is typically less than 3, and that is considered an adequate suppression. Bone age can be done annually, ultrasound pelvis can be done as needed, and typically you can stop at around 10 to 11 years. Medroxyprogesterone acetate, Depo-Provera, we hardly ever use, but sometimes if a patient is not able to afford and we are not able to get through any other source, then we can use it. Typically used for, if you give too much of progesterone, what is going to happen? Both LH and FSH are going to be suppressed, but it also causes Cushingoid features. It also causes bone loss. And it does not have any height advantage. So it can be occasionally used when a child has, the only concern is menstruation, which they want to suppress. GnRHA plus GH, some people use in dire circumstances when the predicted adult height is very short, the child has come to you very late, but it is experimental and not something to be done routinely. For peripheral precocious puberty, we've already discussed. The most important thing is, of course, the etiology. Based on the etiology, you do surgery for tumors, medical management of CAH, hypothyroidism, that suffices. Main classes of drugs are steroidogenesis blockers like ketoconazole. We hardly ever use it because, of course, it will cause adrenal insufficiency also. Then androgen receptor blockers for males like spironolactone, flutamide and bicalutamide. Aromatase inhibitors, they can be used in both boys and girls because the main advantage is that they will reduce estrogen production, so the bone age advancement would reduce. For example, in boys with CAH, with peripheral precocity, sometimes we use aromatase inhibitors, or in testotoxicosis, typically bicalutamide plus anastrozole is used. And estrogen receptor blocker like tamoxifen. And if they progress to central, then they have to be given GnRH agonists. There are 3 MCQs if we have time. We can quickly. Okay. So first one, an 8-year-old has recently developed pubic hair and adult body odor. She also has scattered comedones on her forehead. SMR for pubic hair is 3. SMR for breast is 1. Her linear growth continues along the percentile established by age 2 years. The most important conclusion is, which of these? Is she experiencing normal adrenarche? Does she require immediate evaluation for a masculinizing tumor? Or will she have pubertal concentrations of FSH and LH? Which one do you think is correct? How many of you say it is A? B? C? None of the above, that's not an option. So I think, I would say it is A. Would most people agree? Yeah. Okay, a 1 year and 8-month-old girl, the picture is also there. She is She has a stable SMR stage 3 breast development noted by the mother for the past 9 months. Her linear growth velocity has remained at the 50th percentile since age 1 year. The remainder of her examination findings are normal. Okay. So her height is appropriate for her age. She only has this SMR stage 3, but the mother has noted it for the last 1 year or so, 9 months or so. And she's a young girl, 1 year, 8-month-old. So most likely conclusion is that is she experiencing benign premature thelarchy? She must be evaluated for precocious puberty now, needs suppressive doses of GnRH to prevent short stature. A, good. So many people are saying A, it is A. And last one, a 3-year-old boy has recently experienced accelerated statural growth, impressive muscular development, and enlargement of his phallus. Testes are symmetric, volume of 8 ml, and injection of GnRH results in increased LH release. The most appropriate next step is bone age studies of the wrist, MRI of the brain and pituitary, serum 17-hydroxyprogesterone measurement, serum testosterone measurement. B, definitely B. You can't sit back and waste your time doing other investigations when you have clearly a central precocious puberty. Thank you.
Thank you, ma'am, for the beautiful presentation and taking us through these variety of rare cases. And I think the residents must be motivated to evaluate and examine these cases more carefully next time they see those cases. Thank you once again.
I would now like to request Nishant Verma sir to present a memento to Vandana Jain ma'am. I would like to invite Asin Singh sir to introduce the next speaker, Dr. Avivar Avasthi sir.
Yeah. Dr. Avivar Avasthi is a young endocrinologist currently working at Kasturba Medical College, Manipal. And he will be talking on the topic autoimmune endocrinopathies. Dr. Avivar. स्क्रीन शेयर करनी है स्क्रीन ये शेयर स्क्रीन
Yes. Yes. Mic सब खुला है?
on.
हाँ ठीक है. Okay, start.
Hello, good afternoon, everyone. Sorry for the slight delay. My name is Dr. Avivar Avasthi. I am an assistant professor in KMC Manipal, and I would like to thank the Department of KGMU for allowing me to speak in this occasion. So, coming to the wise words of Swami Shivananda, he said, tolerance is a sign of growth on the spiritual path. So, how does this relate to my topic? It is tolerance. So, before we go to the actual topic at hand, I would like to ask 3 questions, following which I don't want you to tell me the answers now, but let's see if you get them correct or not. I know the India-Pakistan match is going on. You aren't very interested right now, and it's post-lunch, but do bear with me. So the first question would be, which of the following clinical entities are part of autoimmune and polyendocrine syndrome type 1? You have these options. Just think of whatever answer you think, and then we'll go to the next question. And probably by the end of this talk, you might be able to answer it. The second question would be, which antibody has the highest specificity for APS1? If you know the answer, you can say it, or you can just think in your mind. At the end, maybe you'll have a better idea of this. And the third question would be, in any child who's newly diagnosed with type 1 diabetes mellitus, which antibody should routinely be done? It's mandatory as per the ADA. Which ones have to be done at the onset of type 1 diabetes? We can look at this and we'll come back to this at the end probably. So coming to the case 1, so this was a 6-year-old boy who had presented with recurrent vomiting episodes. The latest one was for 1 day, but on inquiry, he had these similar episodes for the past 3 years. Other than that, he had this pain abdomen, and his birth history, postnatal history were not significant. However, it was noticed by the mother that he had fungal infection since 8 months of age. The past history, as I said, he had recurrent episodes of fungal infection since 8 months of age, and in the oral cavity and skin in particular for the past 3 years, with recurrent vomiting since the past 3 years. Making a pedigree chart, his parents were separated. He was living with his mother. He had an elder sibling who was not involved, and on the father's side, his father's sister had expired at 15 years of age. The exact cause was not known. So on examination, the child had an adequate height, weight was on the slightly lower side, BMI was less than 3rd percentile, pulse was steady, tachycardic, BP was low, respiratory rate was 20, peripheries were cold, clinical signs of dehydration were present, hyperpigmentation was present over the lips and soft palate, oral candidiasis was present, onychomycosis was present. His SMR was unremarkable, systemic examination was unremarkable. To keep up with the time which I've been allotted, I'll just present the main the labs which we had done. His cortisol was 2, ACTH was more than 1000. PTH was normal, calcium phosphate was normal, alk phos was normal. So coming to the natural history, if you remember, he was born in 2007. At 8 months of age, he first developed mucocutaneous candidiasis. He presented to us in 2013 with adrenal crisis, primary adrenal insufficiency. However, on inquiry, his clinical features were present 3 years prior to this admission. So since around 2010, he started developing adrenal insufficiency. In 2016, he was again admitted with adrenal crisis, with septic shock, septic myocarditis, LV dysfunction. He was non-compliant because at that time, the parents were undergoing a separation, so he wasn't very compliant with medicine. 2017, again, he had an adrenal crisis, and at that time, he had hypocalcemic seizures. It was seen that his calcium was low, phosphate was high, PTH was low, and he had some patchy areas of alopecia over the scalp. He was discharged with multiple doses of calcium, which I will tell in subsequent slides, because of which his compliance was poor. However, in 2018, he presented again with hepatic encephalopathy and he had hepatic failure. The routine virology was all negative, and autoimmune panel was sent, which was showing autoimmune LKM antibodies were present, positive. That time he had esophageal candidiasis. He even developed nail dystrophy at that time. And again, he developed symptomatic hypocalcemia in the later part of the year. He was treated with high-dose steroids at that time, and with that, it had improved. Then in 2020, again, in one episode of adrenal crisis, one episode of symptomatic hypocalcemia was present. And the latest admission last year in December was again for adrenal crisis, E. coli sepsis, and symptomatic hypocalcemia. So if you see, it's a progressive disease, and if you see here, it started here. He was diagnosed with adrenal insufficiency here, and it took him around 7 years to develop chronic hypoparathyroidism. After 1 year, he developed autoimmune hepatitis, and he was not compliant with treatment that much, and which led to recurrent admissions in the hospital. So the final diagnosis at the time of the last discharge was APS type 1 with mucocutaneous candidiasis, primary adrenal insufficiency, alopecia areata, nail dystrophy, chronic hypoparathyroidism, and autoimmune hepatitis. He was discharged on tablet hydrocortisone 5 mg, 1/2, fluticort 0.1 mg, calcium citrate maleate because he couldn't tolerate calcium carbonate, which is cheaper, and tablet calcitriol 0.25 micrograms, 2 tablets 4 times a day. With that, his calcium was fairly under control, but his phosphate was elevated. However, he has not come back for follow-up thereafter, and we had counseled him regarding further management for the same, which I will tell in the subsequent slides, for his high phosphate and what it entails for the patients of chronic hypoparathyroidism. Another case of ours, this was in Calcutta. This was a case referred to us from neurology. A 12-year-old boy presented with recurrent GTCS episodes. Coincidentally, they did a serum calcium, which was low, around 6. He also had decreased hearing from the left ear, but there were no similar complaints in the family. Now, in a hypoparathyroidism patient, we have to ask for family history and certain associated features because there are syndromic causes of hypoparathyroidism as well. His postnatal period were uneventful. Negative history-wise, as I said, we had asked for mucosal candidiasis, history suggestive of adrenal crisis, which were not there, history suggestive of myopathy, history suggestive of any thyroid disease, postural dizziness, lethargy wasn't there. No history suggestive of tetany as such. On examination, it was mostly unremarkable. However, postural drop in blood pressure was present. SMR again was unremarkable. There was no hyperpigmentation. Labs-wise, if you see, it was kind of straightforward. Calcium was low. Phosphate was high, significantly high if you see here. Corrected calcium would be again lower because the albumin here is more than 4. There's a correction formula which you would all be knowing. In all cases of hypopar or hypocalcium, we have to do a serum magnesium, and here it was done, which was normal for age. Calcium, potassium were normal. Again, we were focusing on sodium and potassium were normal, and in adrenal insufficiency, we have to look at these two. In primary, sodium would go down, potassium would go up. Secondary, only sodium would go down. Again, the reason is, I think, known by you people. TSH is normal. Other antibody profile was done, that is TPO, which is the commonest and cheapest, was negative. PTH again was low. We also did an ABG, which was normal. Because of syndromic causes of hypopara, we have certain things like CASR mutations, or we have mitochondrial diseases. For all that, we had done evaluation, which all came back as negative. However, he had sensorineural hearing loss in the left ear. Now, coincidentally, in view of postural hypotension, which persisted in the ward, we just sent a basal cortisol and ACTH because both were free in our hospital. We saw a cortisol of 6.4, ACTH of 147. Now, if you look at the serum cortisol 6.4, it's not very low. It falls between that gray zone of around 4.5 to 14. It's in that gray zone. Anything less than 3.5 for sure, less than 4 most likely is adrenal insufficiency. But here it's in the gray zone. But since we chanced on doing an ACTH concomitant, it was 147. So the dictum states any ACTH in triple digits with a low normal serum cortisol is most likely primary adrenal insufficiency. So you have to do a stimulation test, which is a syntropin test. Furthermore, any level of cortisol and ACTH of more than 300 is primary adrenal insufficiency. There's no other diagnosis because that's the maximal stimulation which can be done to the adrenal. So we did a post-syntropin test here. It was 14.6. Here the cutoff is around 18. So it was less at 30 minutes. We also wanted to do an aldo and renin, but due to cost constraints, we only did aldo because renin is 3 times more expensive than a plasma aldo. So the aldo was normal. Most likely the renin would have been elevated here. So a case of sporadic chronic hypopara also became, coming back to this, we also did MRI imaging, which showed T1 as well as T2 hyperintensities present in the basal ganglia, which is very common in hypoparathyroidism. If T1 is hypo, it means it's unorganized calcium. If it is hyper, it means it's organized calcium. Unorganized calcium can resolve. Organized calcium generally does not resolve with treatment. So the diagnosis here was APS1 with hypoparathyroidism and stage 3 primary adrenal insufficiency. Primary adrenal insufficiency goes through 4 stages. So it was stage 3, which is almost became overt here, and left side sensory neural hearing loss. So in our patient here, we gave Hysone. Again, the dose calculation I'll tell towards the end when I talk about management. Calcium carbonate, which he could tolerate and is very cheap compared to the other preparations. Calcitriol. And for this patient, since in West Bengal we had facilities to provide treatment to the patient, we had also started teriparatide on his anti-epileptic medications were present. However, this was just before the second wave of COVID. The second wave came and he was lost for follow-up thereafter. So I cannot show you the progression of this patient. So coming to the main topic now, APS, that is autoimmune polyendocrine syndrome. As we know, the immunity of ours comes in 2 parts, that is the innate and the acquired. So in innate immunity, which we are born with, that is the skin barrier or our white blood cells, or there are certain molecular patterns which are present within the cell, which when the cells are broken up, destroyed due to apoptosis or infection, they release certain molecular patterns, that is pathogen associated or damage associated patterns. These go and they activate our acquired immunity, which is antibodies, B cells and T cells. So what is APS? So APS is an autoimmune polyendocrine syndrome, are clusters of endocrine abnormalities occurring in discrete patterns in subjects with immune dysregulation. These permit treatment and anticipation of associated symptoms, systemic or other hormonal deficiencies. Now, APS is a misnomer because it's not only polyendocrine, there are other features which are non-endocrine as well, which are present in these syndromes. Prevalence-wise, it's broadly classified into APS type 1, which is mostly recessive, might be dominant in rare cases, and type 2, which is polygenic. APS2 is very common as compared to APS1. Coming to how the pathogenesis of this, as I said, tolerance, when there is loss of tolerance or when tolerance does not develop is when autoimmunity starts. It occurs in 2 stages. One is the central, which occurs in the thymus and bone marrow during development of the fetus. And the other is peripheral, which involves energy, clonal deletion, ignorance, suppression, and immune deviation. So coming to the central immunotolerance, which occurs in the thymus, here when a pre-T cell is formed, the unproductive T cells, which do not elicit an immune response, undergo apoptosis. Furthermore, these pre-T cells are exposed to autoantigens. Those which are highly reactive to autoantigens and those which have no avidity to autoantigens are undergo apoptosis, and only those which have low avidity to autoantigens are then progress to maturity and they go into the bone marrow. Now, coming to the central tolerance in the thymus, in the thymic, medullary thymic epithelial cells, there's one very important gene called the AIRE gene. It is required for immune tolerance. So when an autoreactive T cell comes to the thymus, it binds to the AIRE positive medullary thymic epithelial cells. So when AIRE is present, these autoreactive T cells either undergo apoptosis or they form T regulatory cells, Treg cells, which are FOXP3 positive, which I will show in the subsequent slides. So if there is AIRE deficiency, these autoreactive T cells, they persist, they lead to autoimmunity, and Treg cells are not formed. Coming to the peripheral immunity, when an autoreactive T cell comes and binds to a T cell, we have regulatory T cell which goes and inhibits this self activation. Now when IPEX, that is another entity which is known as immune dysfunction, polyendocrine, and enteric dysfunction, X-linked disease. So in IPEX, there is direct deficiency of FOXP3, which is in part of the Treg cell. So when either AIRE is deficient or if FOXP3 is deficient, there is overactivity of the autoreactive T cell, which forms autoimmune complexes, and B cell mediated antibodies are formed. So coming to the natural history of immune disorders, so there is a genetic susceptibility. For example, in patients with maybe APS2 who have MHC predisposition, so there might be a genetic susceptibility. This leads to triggering of autoimmunity. So there might be various causes of triggers. For example, sex hormones, sex chromosomes. In women, they have an extra X chromosome and they have higher estrogen, which is implicated in triggering of autoimmunity. That's why women are more commonly facing autoimmune conditions. Others can be environmental triggers like viruses, bacteria, drugs, sunlight, diet, chemicals, as well as unpredictable factors, which are also known as stochastic factors. So after triggering of autoimmunity, there is subclinical inflammation or subclinical endocrine target organ damage, which leads to not an overt disease, but there is progressive damage, and this subclinical phase leads to overt disease. So the autoantigens again can be organ specific or non-organ specific. If it is organ specific, it can be to either the cellular receptors, intracellular enzymes, or the secreted peptides. And as I had already said, the effectors would be either the humoral immunity, antibody mediated, or T cell cellular immunity. So the autoantigens present would be against the pituitary, which is kind of little rare. Most commonly, you would see the thyroid. Thyroid can be either hypothyroidism, that is Hashimoto's thyroiditis, or it can be Graves, that is due to TSH receptor antibodies. Lungs, which can cause pneumonitis. Liver, as I said, autoimmune hepatitis can be seen. In stomach and intestine would lead to pernicious anemia, celiac disease. Parathyroid, due to antibodies against NALP5, which leads to chronic hypoparathyroidism. In melanocytes, which is thyroxine hydroxylase, here it leads to vitiligo. Adrenals, there are multiple enzymes, but the commonest antibodies are against 21-hydroxylase, which leads to primary adrenal insufficiency. Pancreas, as we know, type 1 diabetes would be either, ma'am has already told in the first two presentations, that is GAD65, ZNT8, as well as IA2. And the gonads, most commonly or more specifically in women, which leads to premature ovarian insufficiency. Coming to the immunogenetics of APS1, it is due to defects in the AIRE gene, which is present on chromosome 21. So there are multiple types of inheritance. Most commonly are autosomal recessive. However, there is one mutation which is present in the SAND and PDH1 domain, which is dominant negative, which leads to autosomal dominant inheritance of APS1. Rest, most of them are autosomal recessive. Now, APS2 is mostly polygenic, which is due to HLA, MICA, PTPN22, and CTLA4, which are all required for immune system of the body. Others might be TMI also cause it, but most of them are HLA, PTPN22, CTLA4, and MICA. And all of them, if you see, the common diseases occurring are type 1 diabetes, celiac disease, primary adrenal insufficiency, and in HLA, PTPN, and CTLA4 all cause Graves' disease as well. All of them are polygenic in nature. And IPEX syndrome, as I already told, it's an X-linked disease caused due to defects in the short arm of chromosome X. It leads to mutated FOXP3 gene expression, relates to decreased Treg cells, and Treg is required to reduce autoimmunity, as showed in the first few slides. They also develop antibodies against harmonin and vilinin, which are present in the intestinal brush borders, as well as the renal proximal convoluted tubule. That's why they have enteric dysfunction and they have renal dysfunction in the form of chronic tubulointerstitial nephritis. Now, prior to 2004, it was more complex that APS was classified into APS 1, 2, 3, and 4. But in 2004, there was a very nice review article in the NEJM where Eisenbarth et al. Argued that APS1 is due to mutations in AIRE gene, whereas APS2 is polygenic. It can happen in any of the four major ones which I showed earlier. So why are we having classification as 1, 2, 3, 4? It should be 1 and 2, akin to types like type 1 and type 2. So there is still a controversy amongst endocrinologists. Some of us say no, 1, 2, 3, 4 gives a better idea what's happening. Some say no, 1 and 2 is enough. The Japanese certainly still follow 1, 2, 3, and 4. So coming to the clinical features, APS1, it occurs earlier, that is childhood to adolescence. There is no gender predominance. Average age is 4 to 5 years. And classically, around by 5 years of age, they develop chronic mucocutaneous candidiasis, hypoparathyroidism by 5 to 10 years, and Addison's disease by 12 years. And immunodeficiency is present here. Whereas in APS2, it occurs later on, adolescence onwards to an adulthood. As I said, X chromosome, estrogen presence, female predominance is higher. And the classical features would be type 1 diabetes, chronic thyroiditis. It can again be hypo as well as hyper, and Addison's disease. Here the immunodeficiency is absent. Now other features might also be present in the form of autoimmune hepatitis, pneumonitis, vitiligo we already discussed, periodic fever where rash is present in APS type 1. There might be antibodies against the bone proteins, which might lead to a reversible form of metaphyseal dysplasia, which is reversible with calcium and vitamin D supplementation. It's not exactly rickets. Furthermore, they might develop other autoantibodies against some renal proteins, which leads to tubulointerstitial nephritis. And type 1s are more associated with apparent mineralocorticoid excess that would be due to tubulointerstitial nephritis itself. Type 1 may also have hyposplenism. So coming to one very good landmark paper, it was published by MAM and Department of SGPGI, where they looked at a longitudinal follow-up of patients in India with APS type 1, where they saw that the commonest disease entity here was chronic hypoparathyroidism, which was present in almost 92% of children. Following which, it was cutaneous mucocandidiasis, and Addison's disease was there in around 50%. Hypogonadism was around 30%, and alopecia was there around 25%, and so on. Looking at some clinical pictures, here we can see there is some enamel hypoplasia present, which can be either white powdery or it can be pigmented yellowish. Both are forms of enamel dysplasia. Furthermore, here we can see a patient of Addison's. Here we can see mucocutaneous hyperpigmentation. This is a different patient. Here we can see mucocutaneous candidiasis present. In our patient, he also had esophageal candidiasis when he was severely sick. Furthermore, here we can appreciate alopecia areata. And the important thing is, if you are strongly suspecting APS, especially a fair-skinned child, you should always refer to a dermatologist to a wood lamp examination, because in fair-skinned vitiligo might not be apparent. But here, if you see a wood lamp, it might show a spot of vitiligo. Here we can see nail candidiasis in a child. And if you order peripheral smear, here you can see something, and if somebody would want to tell what it is, I've already said they develop hyposplenism in APS1. So what would this be? Howell jolly hota hai? It's Howell jolly body. Howell jolly bodies. So coming to the endocrine manifestations of APS 1, 2, and IPEX, Addison's is present. Mean age would be around 8.6 years for development. In our Indian cohort, around 50% had it. Hypoparathyroidism by around 10 years. Chronic lymphocytic thyroiditis. Type 1 diabetes, which is kindly later onset. Hypogonadism. Females most commonly are associated, rarely it is in males. Growth hormone deficiency, if there is a Tudor domain binding protein 6 antibody, rarely that can cause growth hormone deficiency, and apparent mineralocorticoid excess, which I already told. In APS2, Addison's is generally the presenting complaint around 50%. The rest 50, they develop it after type 1 diabetes or thyroid dysfunction. Hypoparathyroidism here is rare. Type 1 diabetes can occur in all ages from around 6 months up to maybe 20 to 30. That is LADA, latent autoimmune diabetes, is also a component of APS2. Hypogonadism is rare. Hypophysitis is more common in 2 as compared to 1, and it's associated with thyroid dysfunction. Whereas when we see IPEX, there is autoimmune thyroid disease and neonatal type 1 diabetes. Now, why I have marked this as red? It takes around 6 months for the immune system to develop. So having type 1 diabetes below 6 months of age in an infant or neonate is very rare because there is not enough sufficient autoimmune response in the child, newborn, to develop type 1 diabetes. IPEX is the exception where IPEX patients develop neonatal type 1 diabetes. However, there are certain case reports where they have developed type 1 before 6 months of age with DKA, which were IPEX negative, but that is the exception, not the rule. Coming to dermatological manifestations, majority of APS1 have chronic mucocutaneous candidiasis, which is very resistant to treatment, requires a very lengthy treatment. Alopecia, vitiligo, dermatitis herpetiformis is not reported with 1, it is reported with 2. And as I said, periodic fever with rash, you have to look out for that. In APS2, candidiasis is not seen outside children suffering from type 1 diabetes. Alopecia is occasional, vitiligo is seen, and dermatitis herpetiformis is reported. Now, again and again, I'm focusing on dermatitis herpetiformis. If you go back to that first question where I asked for type 1, so celiac screening is a must for type 1 newly diagnosed children. And eczema and alopecia is also seen in IPEX. Coming to GI, malabsorption is common in APS1. Autoimmune hepatitis is seen in 12%, as well as pancreatitis. APS2, malabsorption, even though it is uncommon, the commonest cause for malabsorption would be celiac disease, primary biliary cirrhosis, and in IPEX, enteropathy, autoimmune hepatitis, as well as pancreatitis. Again, this is a busy slide, so I would just like to focus on certain things. All three, that is APS 1, 2, and 3, will have hematological involvement. However, hypersplenism is seen in APS1, pure red cell aplasia is seen in 1, whereas IgA deficiency and thrombocytopenia are seen in both 2 and IPEX. Ectodermal, as I said, enamel hypoplasia is seen in 1, nail dystrophy and tympanic membrane calcification is seen in 1. Others, it is not reported. Neurological, till recently, I did not find any associated clinical neurological manifestations for 1, bar certain case reports which I recently found, which they said there is autoimmune cerebellar degeneration and Miller-Fisher syndrome. In APS2, myasthenia is very common, Stiffman syndrome, Parkinson's, CIDP, as well as cerebellar ataxia, and IPEX, there is myasthenia. In APS1, as I said, they can have metaphyseal dysplasia, Sjogren syndrome, myopathies, nephritis, as well as pneumonitis. Whereas in APS2, they might have idiopathic heart block, myocarditis, sarcoidosis, GPS, and membranous glomerulonephritis and interstitial nephritis seen in IPEX. So coming to the diagnostic criteria for APS1, this is kind of old when it was originally prescribed, where any 2 of the 3, either the classic or the adjunct triad, that is chronic mucocutaneous candidiasis, hypopara, or adrenal insufficiency, any 2 of these, or the adjunct triad, that is urticarial eruption, intestinal dysfunction, enamel hypoplasia, go with AIR sequencing, interferon alpha or omega antibody screening, which are a class of interferon class 1 antibodies, which are the most specific for APS type 1. So again, any 2 of the following which I just mentioned, or clinical features which are not matching your APS1 criteria, that is Addison disease in patients less than 20, primary ovarian insufficiency, enamel hypoplasia, periodic fever, non-infectious keratitis, autoimmune hepatitis. If there is no presence of interferon antibodies, it is organ-specific autoimmunity or APS2. If interferons are present, if the patient is affording sequence EIRE, if there is no mutation present, and if a thymoma is present on CT, which is again depending on if myasthenia is present or not, it would be myasthenia gravis or CID. If it is not present, it is APS1-like. If 2 mutations are present in AIRE, it becomes APS1. If there is a dominant negative mutation, which I had already told, that is in the SAND or PDH, it is non-classical APS1. So what to do? As I said, we have to anticipate. In the first case, the patient presented with adrenal crisis. At that time, we had assessed for calcium phosphate, knowing it might be present because he already had mucocutaneous candidiasis. It wasn't present. So he didn't come for regular follow-up, so he presented with hypocalcemic crisis. So that time we found out that he had hypoparathyroidism as well. So when we get a patient with APS, we have to screen at least the first degree relatives. So the first patient, we had screened the relative, that is the sibling, elder sibling. That sib was negative for any of these problems. We did not screen for the antibodies because it is very expensive and the availability is scarce. So once the serological, we get a diagnosis of APS 1 or 2, there should be screening periodically, at least annual, in the form of electrolytes. If they are willing, then at least a basal cortisol plus minus ACTH annual, physical examination for alopecia, at least a TSH, free T4 for autoimmune thyroid disease. TPO is kind of expensive, so it can be done maybe once in 3 years. Celiac disease should be done a diagnosis of type 1 or when there are symptoms suggestive of gluten intolerance, as well as if the affordability is not an issue, annual screening should be done. If not, once every 2 years should be done. Pernicious anemia, again, ask for a CBC with a smear. If they are affording B12 to be done at least annually, and antibodies, which is very rarely done in clinical setup, should be done once every 5 yearly. Primary hypogonadism, I would say only clinical features are enough because as of now, antibody testing is not done. And type 1 diabetes, you can do annual HbA1c fasting or PP. And if positive, do the GAD screening or IA2 or ZNT8. GAD is the cheapest, as ma'am had already told. In APS1 follow-up, minimum of 2 follow-up visits per year, annual follow-up of asymptomatic carriers if financially affording, and all SIBs of patients with APS have to be screened, as I had told. Screening of 21-hydroxylase for adrenal insufficiency and NALP5, that is for hypoparathyroidism, is not available in our country, but it is done in the Western countries. Coming to the treatment, endocrine replacement therapy, endocrine and non-endocrine. In endocrine for primary adrenal insufficiency, hydrocort, as you should be knowing, before maturation of growth plates, hydrocortisone should be given at 8 to 10 mg per meter squared with fludrocortisone 0.05 to 0.2 mg per day. In the neonatal period, you might require a higher dose, 0.2 mg, but after 1 year of age, it becomes lower. Stress dose of hydrocortisone should be explained in cases of high fever, recurrent vomiting, intractable diarrhea. They have to take double the dose, or if they are unable to do that, to take injectable based on the age. Neonatal period 25 mg, infancy 50 mg, school going 100. Hypoparathyroidism, calcium at the dose of around 30 to 70 mg per kg per day has to be given. That is elemental calcium. So if you're giving calcium carbonate, that has around 40% elemental calcium. And in the first patient who was intolerant, we had given citrate maleate, which has a 20% elemental calcium in it. Cholecalciferol is given, that is given so that the efficacy of calcitriol improves, because cholecalciferol displaces calcitriol from the vitamin D binding protein. Calcitriol is given at around 20 to 60 nanogram per kg per day in 2 divided doses. Thiazides are given in certain cases. If this is beyond the scope of my presentation, but hypoparathyroidism, the treatment is very tricky because the phosphate is high, the calcium is low, and if you know, there is something known as the calcium phosphate product. So if the calcium phosphate product is more than 55, it might lead to nephrocalcinosis, nephrolithiasis, and ectopic calcifications. So we have to keep that CPP less than 55 mg squared per DL squared. So thiazides cause calcium retention, they cause hypocalciuria. So in some cases, when we are giving calcium, especially calcium carbonate, because that acts as a phosphate binder, so that would increase the calcium, would decrease the phosphate. Addition of thiazide would, in a way, reduce the urinary calcium excretion. So the targets would be, I will tell in the subsequent slides, but it's a very tricky treatment. It's a fine balance for hypoparathyroidism. And there is a role of 184 parathyroid hormone administration. That is for refractory cases. In one of our patients, we had tried teriparatide 20 microgram OD. Now, this is indicated in those where the phosphate is not coming down with proper treatment, or those who have iatrogenic renal involvement, that is nephrolithiasis or nephrocalcinosis, or in those where the dietary supplementation of elemental calcium, not the calcium tablets, elemental calcium is more than 2.5 grams per day, or the activated vitamin D is more than 1.5 microgram of calcitriol per day, and alpha calcidol is in a easy to remember double of calcitriol, so more than 3 microgram alpha calcidol per day. Furthermore, as I said, hyperphosphatemia, which is not coming down with traditional treatment, or the CPP persistently elevated more than 55, or a GI disorder or post-bariatric surgery which is leading to malabsorption. These patients, children, can be given recombinant PTH. However, the literature only states for 184, teriparatide is only 134. It is experimental, it's not written in any literature or any guidelines as such right now. And in type 1 diabetes, I think ma'am in the morning has given an excellent lecture on multiple subcutaneous insulin injections, that is basal as well as bolus. There is no role of premixed insulin in pediatric age groups. Furthermore, in LADA, adult patients as well, those it's not very advisable to give a premixed insulin. There also mostly they need basal bolus insulin. As I said, monitoring of chronic hyperparathyroidism, it's very important. It's a very dicey game of balancing the calcium as well as the phosphate. So the goal of the therapy would be to keep the calcium between 8 to the lower limit of normal. Don't keep it within the normal range. The child should be symptom free. Symptoms would be tetany, paresthesias. So if they are not there, it's between 8 to the lower limit. In our center, it is 8.4. That is adequate. Phosphate should be as low as possible. It should be near the upper range of normal. And as I said, CPP should be less than 55. So initial evaluation should be once every 3 months, where you would order a calcium, phosphate, magnesium, albumin, because if you're looking at ionized calcium, no issues, but most centers don't have ionized calcium. We have total calcium. So calcium, we look at albumin to look at the corrected calcium, and then we titrate the dose. A simple rule of thumb is if phosphate is very high, calcium is borderline low, you try to reduce the calcitriol, go up with the oral calcium, and try to add a thiazide diuretic. So it's not very simple, and it's beyond the scope of my 40-minute talk here. But basically, on follow-up, what the guideline says, we have to do a 24-hour urinary calcium to rule out hypercalciuria. In that, they say the cutoff is more than 4 mg per kg per day, but it's technically unfeasible to ask for a child to give a 24-hour urine sample. So what we do is we do a spot urine creatinine ratio, mg per dl. Anything more than 0.15 or anything more than 0.2 is very high. So that would necessitate an addition of thiazide diuretic here to reduce the incidence of nephrolithiasis. Endocrine replacement for thyroid, if it is Graves, you give anti-thyroid drugs. In pediatric age group, propylthiouracil is contraindicated, so it's either methimazole or carbimazole. Dose would be 0.1 to 1 mg per kg per day. Follow up after first 6 weeks and just titrate based on the free T4 and T3. Then when a patient or a child comes with Graves' disease, we try to classify them into those who are likely to go into remission, and those who are very unlikely to go into remission. Those which have a high trap titer, that is TSH receptor antibodies, those who have high trap titers, free T4 at diagnosis more than 1.5, a large goiter, and pre-pubertal onset of Graves' disease have a lower chance of remitting, whereas those who have lower free T4, smaller goiter, absent or near normal trap titers, and post-pubertal onset of Graves. So in those cases, we should anticipate that the likelihood of remission are low, and in that case, we can either ask them for a radioiodine ablation or surgery. Both are relatively safe, and long-term longitudinal studies have shown no increased risk for malignancies with I-131 radiation. Hypothyroidism, we gave levothyroxine. As you know, in the pediatric age group, the dosing is higher than adults. Infants, it's very high. 1 to 5 years onwards, it's a steady decline of dose for pediatric hypothyroid individuals. Hypogonadism, again, is not part of your repertoire. Furthermore, metaphyseal dysplasia is reversible, just calcium vitamin D supplementation. For non-endocrine management, chronic mucocutaneous candidiasis, again, it's either oral fluconazole or nystatin. Chronic diarrhea or bacterial overgrowth based on the antibodies which are prescribed. Or if it is celiac disease, gluten intolerance, so avoid gluten in the diet. Chronic active hepatitis, high-dose steroids have to be given. Keratitis is topical immunosuppressants. Immunomodulatory therapies are experimental at this stage. APS1, as I said, they have a higher risk for hyposplenism, so pneumococcal vaccination should be done, if not already done. In IPEX, calcineurin inhibitors are given. In the meanwhile, we ask for the child to register for hematopoietic stem cell transplantation. Coming to the prognosis, mortality in APS1 has been studied very nicely, and highest mortality is due to oropharyngeal squamous cell carcinoma, followed by adrenal crisis, hypocalcemic crisis, autoimmune hepatitis, then renal as well as lung involvement. APS2 longitudinal studies are lacking because it's very vast, polygenic, most of them are underdiagnosed, and the mortality is due to type 1 diabetes as well as adrenal crisis. Coming to IPEX, a recent publication showed that the 20-year survival data showed there was no statistically significant difference between hematopoietic stem cell transplantation and chronic immunotherapy, because the highest rate of mortality in post-transplant was due to transplant-related side effects within the first 100 days. But after that, the survival stabilized in these patients. So coming back to the question which I had asked in the beginning, which of the following entities are part of APS1? I hope you would have thought of all of the above, because all are present. Which antibodies have the highest specificity for APS1? As we know, interferon class 1 have the highest specificity, is done in many leading private labs in the country. And third was, what additional testing should be done in children with type 1 diabetes at diagnosis, which has to be done. That would be TSH, anti-TPO, anti-TG, and total IgA and anti-tissue transglutaminase IgA antibodies has to be done in type 1 diabetic patients. So thank you. And are there any doubts?
definite history of bone pain which was there, and the alkaline phosphatase levels had gone up. So do you really think that this is a very significant scenario? So we'll start off with this first case. The parents are concerned that there is bone pain and the alkaline phosphatase levels have gone up as 1100. At this point of time, so calcium was 9.4 and was labeled as refractory rickets. Do you agree with the diagnosis? So there is, after a single dose, increase in the level of alkaline phosphatase. How many of you will be worried and you would like to evaluate immediately? So people did work up and they did a blood gas, a calcitriol and a PTH, and everything was found to be normal, and what we got was an X-ray, and that X-ray showed a clear-cut line of healing. So the message here, which I'll discuss a bit later also, is that once you treat, you expect alkaline phosphatase to go up, because alkaline phosphatase is a marker of bone formation. It is, in fact, telling you that the bones are healing now. So just go for a line of healing. Do not go for these biochemical parameters. This is a normal response, which is there in that perspective. Now we have the second case, 14-year-old boy with rickets who had an onset 4 years ago, has received huge doses of vitamin D. He has shown no line of healing and developed nephrocalcinosis. So on one hand, we had a child who was absolutely normal, was unnecessarily being investigated for refractory rickets. This is another scenario in which the diagnosis was missed. So this is a scenario where we should have evaluated and got the diagnosis. Now, if you look at the child, he had a later onset, predominantly of the lower limbs, and there were classical features. So this is a classical presentation of which form of rickets? This would be later onset, lower limb involvement, refractory rickets. So hypophosphatemic rickets is what the classical would have been. And if we had done the phosphorus here, we would have got the diagnosis. So rickets clearly is a difficult situation to assess. On one hand, we are missing individuals who are refractory rickets, and on the other, we are doing too much workup, causing more confusion and problem. It's a common condition. Most cases are nutritional, but we need to really evaluate refractory in a proper fashion. So over the next half an hour or so, I'll talk a bit about pathophysiology of rickets and then carry forward an approach based upon that pathophysiology to achieve a diagnosis in that regards. All of you can go and have a look at our portal, MediClasses, which got a lot of videos which cover different aspects of pediatric endocrinology. So if we talk about rickets, we're talking about two major substances, calcium and phosphorus. Now, which of these is more important, calcium or phosphorus? So if you have normal level of which of these, you will be less likely to have rickets. So there are only two choices, calcium or phosphorus. The most important is phosphorus, because phosphorus is causing the apoptosis of the growth plate. And rickets is the problem wherein the growth plate is not apoptosing. So if your phosphorus is low, then only you will have rickets. So traditionally, we talk about calciopenic and phosphopenic. I'll see how both of them are linked. Now, if we talk about the calcium, most of our calcium from a chronic perspective is coming from the absorption from what we are taking, and that is regulated via the vitamin D. We are all aware about the vitamin D pathway. Most of it is actually produced via the sunlight, and some of it comes from the food, and then it is activated in the liver by 25 hydroxylase to 25 hydroxylase vitamin D. It is 1-alpha hydroxylated in the kidneys, and then this calcitriol causes the increased production. There is also a mechanism to not allow too much vitamin D to be there in the body, so body will inactivate the process to the 24-25 hydroxy vitamin D from that perspective. So clinically, we can classify rickets into two forms. One is phosphopenic, the other is calciopenic. Phosphopenic means that you have a deficiency of phosphorus, while whenever you talk about calciopenic, you also have phosphorus deficiency. Why does calcium deficiency cause phosphorus deficiency? Because once your calcium goes down, what goes up? PTH goes up and phosphorus goes down. So anybody who has hypocalcemia will also have phosphorus deficiency. So essentially, phosphorus deficiency is uniform in all forms of rickets. So phosphopenic forms typically can be a problem in the tubule, Fanconi syndrome, hypophosphatemic rickets. Typical presentation is late onset, lower limb involvement with a normal PTH. This is your classical picture as the second case I saw. Now, you can have problems in terms of nutritional problems, in terms of lower sun exposure, lower intake of calcium. Now, many people talk about vitamin D deficiency, but our diet often in children is very less in calcium. So, calcium deficiency alone may also cause rickets. So, whenever you are giving vitamin D, always give calcium along with that. If you do not give calcium, you will, one, not heal the rickets often, and second, the individual will go into a hungry bone syndrome. When you give them vitamin D, the body will want to make more bone. If you don't have any calcium, you will develop tetany, hypocalcemia, and bone pain, which happened with the first case. So the pathophysiology will tell you how to go forward in that regards. Now, liver disease is unlikely to primarily cause rickets because you have lot of stores of 25-hydroxylase. So if you have an individual with chronic liver disease who is developing rickets, think of other causes like tyrosinemia, like cystinosis, in which you have tubulopathy along with liver disease. So it's very unlikely for a liver disease to just cause rickets. You can, of course, have a lot of intake of anti-epileptic drugs, which will inactivate vitamin D, and this is going to cause rickets in that perspective. Chronic kidney disease and BDDR1, the problem will be in the activation of vitamin D, and BDDR2 is resistance. These forms will present with very early onset in the first 3 to 6 months of life with hypocalcemic seizures. So I think this is something you need to be very, very aware. So if you understand the pathophysiology, you will know most of the situations. So calciopenic rickets are early. They have tetany, hypocalcemia, and hyperparathyroidism. And all this I'll talk a bit later. The third angle is acidosis. And we read in most of the Western textbooks that proximal RTA causes rickets. Distal RTA does not cause rickets. But in India, distal RTA is often missed, presents late, and we have seen worst forms of rickets, worst forms of fractures coming with distal RTA. So very early onset, think of proximal RTA, but 6-7 years after fracture, think of distal RTA as a possibility, which again becomes important from that perspective. So RTA is an important cause. It will present you with failure to thrive, polyuria, hypokalemic paralysis, and nephrocalcinosis if it's distal RTA from that perspective. Now, if you classify rickets, as I discussed, first of all, think of deficiency like calcium and vitamin D. You will give treatment and they will respond. So most of your cases come here. Do not do unnecessary workup in everybody unless you have given a proper therapeutic trial. And what I mean by that, I'll talk a bit later. Now, within refractory rickets, the issues could be deficiency in the calcium pathway, where you can have a VDDR type 1 or type 2, renal failure or malabsorption, which will have early onset hyperparathyroidism and hypocalcemia. And then you will have acidosis, you will have proximal RTA and distal RTA, typically with polyuria, failure to thrive, and nephrocalcinosis. The third arm will be phosphopenic, in which you will have late onset lower limb involvement with normal PTH. If you remember the slide, most of the approach will be done from this perspective. Now, important thing to remember is that hypophosphatemic rickets, you may have a variant because of the sodium phosphorus transporter in which you will have hypercalciuria. If you do not identify that and give them calcitriol, you will worsen them. So you need to be aware of that. But this is what I'll be talking from here on. So the three questions that a pediatrician needs to answer when encountering a patient with rickets is it really rickets? If it's rickets, it's nutritional or refractory. And finally, what's the cause and how do we treat that individual? So we are all aware about the clinical parameters and features of rickets. Just remember that physiological genu varum is common in infancy. So don't think anybody who comes to you at 1 to 2 years of age with bowed legs has rickets. But if you have genu valgum, that is always pathological. Of course, if you have windswept deformity, that will be significant. We all know about the radiological features of rickets, of cupping, fraying, splaying, all those parameters you look at. There is no role of biochemical parameters in routine evaluation. Now, I see a lot of people get vitamin D in everybody, calcium, phosphorus, ALP in everybody. It is not required unless you are thinking of some other cause, unless you are thinking of skeletal dysplasia, for example, where all these parameters will be normal. Now, once you know about that this is rickets, the next question is, what basically is whether it's refractory or it is a nutritional. So we all have clear-cut guidelines available. So give a good therapeutic course. I would recommend most of cases we would prefer a daily course rather than an intermittent therapy. But if compliance is an issue, every 15 days you can give 60,000 international units beyond 1 year of life. So most of them will come to you after 1 year. So there you can give every 15 days 5 doses and typically repeat the level after around 2 to 3 months, typically getting an X-ray done. Do not worry about the bone pain. Do not worry about alkaline phosphatase. Do not worry about phosphorus levels because they will not really give you a clue. So what happens when you treat an individual with rickets? As you give vitamin D, you increase the calcium absorption and the phosphorus absorption, which basically results in increased serum calcium and phosphorus, which gets deposited in the bone, and you will have, if your body has got low calcium, you will develop hypocalcemia. So hypocalcemia may develop, you may develop bone pain because of bone development and growth, and very importantly, the bone turnover. When you have low vitamin D, both osteoclast and osteoblasts are sleeping. Now they become more active and you will have a rise in alkaline phosphatase, which is a marker of bone formation. So as I said in the first case, rise in ALP is not a marker of inadequate response of therapy. Line of healing is what is most important from that perspective. So what do we label refractory rickets as? If you have given a good course of calcium and vitamin D, typically 60,000 international units, at least 5 to 6 courses you have given, there is no line of healing, think of refractory rickets. But do not be misguided by high ALP, low calcium or bone pain. Very importantly, there are certain conditions which look like rickets which you want to exclude. Skeletal dysplasia, in which all parameters will be normal. Pseudohypoparathyroidism will cause high phosphorus and rickets. Remember, there are only 2 conditions classically which cause high phosphorus with refractory rickets, that is renal insufficiency and pseudohypoparathyroidism. The other would be fluorosis, and often you will see mottling of teeth, yellow teeth, and typical sclerotic picture on this. But this is something you need to be aware of. And in young children, you will get a very unique situation of very low alkaline phosphatase. You expect ALP to be high, but if ALP is very low, it's a rare case of hypophosphatasia. So this is something you need to be bothered about. However, if you have a child who comes to you with rickets for the first time, has a lot of polyuria, lot of failure to thrive, nephrocalcinosis, think of refractory rickets right at diagnosis. Don't wait for such a long period. So now we'll go 3-year-old boy, rickets we discussed already, that in this case, this high ALP is actually not a good indicator. We should not have had worked up in this case. 4-year-old girl with rickets given osteocal 5 ml BD. After 30 days, X-ray shows no line of healing. Do you think this is refractory? This is not refractory. This is inadequate treatment. And in this case, you should have been giving proper treatment, especially vitamin D would have been required. 7-year-old girl with refractory rickets, you can see phosphorus is 7.6. It's high. Creatinine is normal. Calcium is on the lower side and PTH is high. So we have features of rickets with high phosphorus, low calcium, high PTH. I think we were discussing a lot about hypoparathyroidism. This is just the other picture of pseudo-hypoparathyroidism, which can present you with rickets. So high phosphorus, and I'll come to that. The most important investigation to do in a child with rickets is phosphorus. Like the most important investigation to do in a child with hypoglycemia is ketones, which will classify same as phosphorus here in that perspective. So clearly, this was PHP and not refractory rickets or other forms. Now, once we know, the next question is how would you classify? And if you look at the etiology, this was my publication around a couple of decades ago. And distal RTA was the most common cause which we encountered at that point of time. So still distal RTA is very common, followed by vitamin D dependent rickets, and hypophosphatemic rickets is also more common. If you go by more Western data, it is hypophosphatemic which is most common, followed by proximal RTA. But in India, you can't ignore distal RTA as a cause in that regards. Go for history, ask for features of tetany and hypocalcemia, polyuria for RTA, and if you have lower limb abnormalities, think of phosphopenic form of rickets. On examination, if you have anemia with rickets, think of celiac disease, chronic kidney disease. If there is alopecia, this could be a rare form of vitamin D receptor problems, VDDR type 2, which is there. Always get a proper slit lamp examination, particularly if it's a very early onset and you have acidosis. We have seen so many patients with cystinosis and tyrosinemia which present you with proximal RTA. So for cystinosis, look for crystals which will give you a diagnosis. Rarely, you may have hemangiomas which are producing a lot of fibroblast growth factors causing phosphaturia. And of course, especially in our belt, we have to look for the teeth. We often will miss this. You will see fluorosis, which is common in that perspective. If you have significant failure to thrive and you have renal calcifications, episodic paralysis, polyuria, and acidotic breathing, of course, RTA has to be considered. But I would say as part of workup for every patient who comes to you with refractory rickets, blood gas becomes important if your phosphorus is low or normal. We'll try to build up the approach subsequently. Now, if you have lower limb involvement, later onset, coarse trabeculations, recurrent dental abscesses, tendon involvement, and inappropriately low calcitriol, think of a possibility of a hypophosphatemic ricket. That was your case 2, which we discussed earlier in that regards. Now, which investigations, of course, will give you a picture? As we see, ALP is pretty high across board. It's not going to help you in classification. The most important is phosphorus, which will give you a correct classification. And then you will look at urinary calcium, look at creatinine, and look at blood gas. This will typically give you a classical diagnosis. Do not measure calcitriol in a routine case of rickets, because in nutritional rickets, calcitriol may be low, normal, or high. It can be anywhere because it's not a good marker. 25 OST is the best marker for nutritional rickets because it's substrate independent. So now phosphorus levels are most important, but often the problem is that the reference range we get are more towards adult ranges. Children tend to have higher level of phosphorus because it's again part of growing children. So look at these reference ranges to look at, which will help you in classification. Often we spend a lot of time and money in measuring urinary phosphorus excretion. And this is something which I'll talk about and then I'll say how important it is. So a lot of people do a 24-hour urinary excretion or a spot excretion, calculate fraction excretion of phosphorus, TRP, and then there is a TMP-GFR, which basically corrects the phosphorus excretion to the level of phosphorus and GFR. Now, if you look at this formula of TMP-GFR, it is plasma phosphate minus something. So what it tells you is that TMP-GFR will always be lower than plasma phosphate. If your plasma phosphate is 1 or 2, it means the only way you are having hypophosphatemia is urinary excretion. Everything you eat has got phosphorus. So unless you are losing in the urine, you will never develop hypophosphatemia. So I would say this is a very overrated investigation, difficult to do, difficult to assess. But the very fact that you have got very severely low phosphorus, you are losing in the urine. So it's pretty much, I think, don't worry if you can't get it easily done. Look at plasma phosphorus, you will get the idea in a clear-cut picture. Now, urinary calcium excretion is important to identify renal tubular acidosis, typically the distal, and we had discussion in the last session also that we can use a spot sample, which is a good marker of urine to calcium creatinine ratio, and you will get good answer from that. If you have hypercalciuria, think about it. Anybody who has rickets would want to conserve the calcium. If you are losing calcium, you are either having a tubular problem. Essentially, you are having a tubular problem because you should not be losing calcium if your already bones are weak. So that will be a hypophosphatemic rickets with hypercalciuria, dense disease, or renal tubular acidosis are the major causes in that regards. Now, very important group of disorders are RTA. To diagnose RTA, you need 3 things. You need acidosis, you need renal acidosis, and you need a tubular acidosis. So you need to have acidosis, which is metabolic, normal anion gap, normal creatinine, and a urinary anion gap, which is positive, which means ammonium production is defective. So when you are diagnosing RTA, you essentially have to have a normal anion gap metabolic acidosis, normal renal functions, and a positive urinary anion gap. I won't go too much into detail, but to classify, the most important thing to look at is the fraction excretion of bicarbonate, urinary pH, and ammonium production. So if you have acidic blood and acidic urine, basically it means that your body is acidifying. It means it's more likely to be a proximal RTA. If you have a acidic urine with a acidic blood with an alkaline urine, it is distal RTA. It's a acidification defect. So again, simple correlation of pH of less than 5.3 and more than 5.3 will classify proximal versus distal. But of course, often there could be confusions there. So the most important investigations, I would say, phosphorus is most important. Then look at calcium, PTH, urinary calcium and pH. These are pretty much the ones. If your phosphorus is high, there are two conditions to think of: kidney disease and pseudo-hypoparathyroidism. Calcium, not much helpful, but PTH very helpful in differentiating hypophosphatemic rickets from other forms. If your PTH is high in an untreated hypophosphatemic rickets, it excludes hypophosphatemic rickets. Essentially, PTH has to be low in hypophosphatemic rickets, and hypercalciuria will typically tell you that this is a distal or a proximal RTA. So now this was the approach which we developed that time based upon our profile, just to make it more modern in that perspective. Look at the response to vitamin D. If you get, of course, this is a deficiency rickets. If it's no, look at phosphorus. If your phosphorus is low, then renal failure and PHP are out. The next important thing is to look at blood gas. If blood gas shows acidosis, it is RTA. You classify it based upon urinary pH into proximal or distal RTA. Then if the blood gas is normal, then you are dealing with VDDR versus hypophosphatemic rickets. If your calcium and PTH both are normal, this is hypophosphatemic rickets. If you have hypocalcemia or hyperparathyroidism, you have vitamin D dependent rickets you classify using calcitriol. So now if you look at it, the investigations have been delegated depending upon their cost. Calcitriol is only at the end. Don't do calcitriol in everybody. First do a calcium, phosphorus, ALP, creatinine. This will give you a major classification. Then do a blood gas. Then if required, do a PTH. Otherwise, you will keep on doing too much investigations which are not required from that regards. In that perspective. Now, of course, if the phosphorus is high, do a creatinine. It will give you renal failure or pseudo-hypoparathyroidism. So 4-year-old girl with rickets, vitamin D2 courses, no improvement, also has abdominal pain and anemia. Now, parental vitamin D was given. Now, do we give parental vitamin D? Not routinely. It is not recommended except if you're thinking of malabsorption. That's the only indication. If you give high dose vitamin D, your vitamin D will go up and your peak will be too much. You will lose in the urine, the levels will come down. So the oral one gives you a better profile of vitamin D than the injectable vitamin D. But in this case, we gave a parental vitamin D because we thought of something and we got a healing line. So what do you think was missed in this case? Yes, so celiac disease would be something which you have to always consider as an important possibility in this regards. 5-year-old girl with rickets and polyuria, and you can see very short. There is metabolic acidosis. There was base excess of -12 and urine pH was high. So somebody made a diagnosis of distal RTA. Do you agree? Rickets, failure to thrive, short stature, acidosis, and you've got a urine pH which is high. So RTA. But you need to remember that this is a renal tubular acidosis. So this was a very tubular workup. They had not looked into creatinine at that point of time. Phosphorus was high and creatinine was also high. So remember, before we reach to more rarer diagnosis, think of something more common like a chronic kidney disease, which is obvious in this case. 4-year-old boy with rickets, calcium is 8.2, potassium is 3.8, phosphorus is on the lower side, ALP is very high. There is mild metabolic acidosis, as you can see. Now, if you look at here, it looks more likely to be a distal RTA. But what we are seeing here is that there was not much of problems in terms of the clinical manifestation. So what do you think here? Do you agree with distal RTA? As I said, by 4 or 5 years, usually they will have much more severity. The important thing was that vitamin D was very low and PTH was very high. Now, if your PTH is very high, you will also have a Fanconi syndrome-like picture, which will maybe misdiagnosed as RTA. So I will be very, very cautious with this mild level of acidosis labeled as a case of RTA, because often when RTA is severe enough to cause rickets, it's quite severe. This minus 6.5 base excess is very mild. So secondary hyperparathyroidism of any cause can cause the same scenario. 2-year-old girl with failure to thrive and rickets, and we can see very classical rickets. So it's an early onset rickets. There are also fractures which are evident. She is short, failing to thrive. Phosphorus is 1.9. Alkaline phosphatase is very high. The working diagnosis of hypophosphatemic rickets was made. How many of you agree with hypophosphatemic rickets in this case? Phosphorus is low. So do you think it's hypophosphatemic? It is too early. Usually they present late with lower limb involvement. So what we are seeing here, this is not hypophosphatemic rickets. We should rule out other causes like proximal RTA, which is more common in this case. She had actually a proximal RTA and turned out to be tyrosinemia. So our job doesn't end by diagnosing RTA. We have to reach to a particular diagnosis to make the final picture. 12-year-old girl with multiple fractures, and you can see a lot of bony fractures. Classically, she was diagnosed and referred to us as osteogenesis imperfecta. But when we looked at the history, there was failure to thrive, polyuria, and myopathy. There was metabolic acidosis with hypokalemia. I think now we know the diagnosis is very typical. A very severe form of rickets, severe failure to thrive, metabolic acidosis with hypokalemia. Which form? Distal or proximal? This is more likely to be distal because it's a later onset. There is hypokalemia at diagnosis, which is very rare in proximal. So this case, anion gap was there, and we finally made a diagnosis of distal RTA. So beware of RTA as a cause if it's a very, very severe acidosis in that regards. 3-month-old boy with seizures and rickets. What we are seeing here, phosphorus is low. You have a low calcium and vitamin D is normal, calcitriol is high. So what are we dealing with? Very early onset, it's a calciopenic rickets. Calcitriol is high, which means it's there but not working. So it's a vitamin D dependent rickets, type 2, very difficult to treat in that regards. 1-year-old girl with refractory rickets, there is hypocalcemia, calcium is low, phosphorus is also low, ALP is high, PTH is high, vitamin D is high, and calcitriol is not high. So just if you think about the picture, you have the levels which basically are showing that you have got enough amount of vitamin D, but it is not getting converted to calcitriol. So this is VDDR type 2. So if you go by the algorithm, you will get the diagnosis in most cases, right? So this was VDDR, initial, the conversion defect, the problem in 1-alpha hydroxylase. Finally, this case, 12-year-old boy with refractory rickets, you can see clearly, I discussed earlier also, late onset, lower limb involvement, no acidosis, normal PTH, normal calcium. This is hypophosphatemic rickets, and you don't need to worry much. You have to treat. The treatment itself is complicated, which we'll touch base a bit later. Finally, we have got another person who came to us with hypophosphatemia, but he developed nephrocalcinosis. So this was a hypophosphatemic rickets with nephrocalcinosis variant. So whenever you diagnose hypophosphatemic rickets, always check the urinary calcium to see if it's high before you give calcitriol. In that regards, it becomes important. 4-year-old boy with failure to thrive, polyuria and rickets, phosphorus is low, PTH is normal, there is hypercalciuria, there is no metabolic acidosis. So this is a difficult question. Maybe I'll open it. Somebody would like to answer. We just saw this case recently. So there is hypophosphatemia with a normal PTH and hypercalciuria with no metabolic acidosis. Anybody? Dr. Nitin? Yes, that could be one, but it's a bit earlier stage in that perspective. There, urinary calcium becomes high a bit later. A close one to that, there was a urinary microalbumin which was also present. There was amino acid urea. So this is Dent's disease, which is a rare form. So you have to think of all the possibilities from that perspective. And this was the last case, 16-year-old boy with rickets, severe hypophosphatemia, high alkaline phosphatase, and what we are seeing is that there was no family history, but he had a large hemangioma which was present. So this is a FGF23 producing hemangioma, which will cause a loss in that regards. The soft tissue tumor will be able to cause the diagnosis. So we have developed, we've talked a lot about the approach pathways and everything. So we have developed the application which really guides in terms of evaluation of a lot of pediatric endocrine disorders, including rickets. You can have a look at it and it provides a lot of information on that. Finally, on management, the management of course will depend upon the condition. If you have distal RTA, you give bicarbonate, supplements and vitamin D. Proximal RTA, you have to worry about phosphorus as well. VDDR1, you need to give a high dose of calcitriol. VDDR2, very difficult to treat, extremely high doses, and hypophosphatemic rickets, phosphorus, calcitriol, and there are some new treatments which are available, which I'll touch base on. So for distal RTA, the problem is that these individuals will have hypokalemia to begin with. So, but once you start treatment, this hypokalemia improves. So you start with a level of 1 to 2 millimoles per liter, and then try to titrate from that perspective. Proximal RTA, they will not have hypokalemia at initiation, but once you start treatment, they will develop severe hypokalemia. You have to worry about that because this can be a big problem. So their hypokalemia may worsen, so you have to give phosphorus, you have to give potassium, and you have to give bicarbonate in proximal RTA, and often you might need to give a thiazide diuretic. For hypophosphatemic rickets, you can give phosphorus as a treatment. Along with that, you give calcitriol. But the problem is your phosphorus will never rise above a level. As soon as it rises, the PTH is triggered and your phosphorus is taken off from the kidney. So it's a very difficult condition to treat. Recently, there has been a development of a very specific therapy, which is the monoclonal antibody against FGF23, which is burosumab, which may be effective in this condition. Not available in India. It's imported, extremely expensive. But this is a therapy which is commonly used now in Western countries routinely for hypophosphatemic rickets in that scenario. So these conditions will be there. So you have to basically give phosphorus, calcitriol, and of course you can use alpha calcitriol. Phosphorus preparation, we are now getting very easily. We have got the AdPhos preparation. You can get it through the online. It's very easily available. Earlier, people used to make phosphorus solutions by themselves. Some people still do, which is an inorganic one. Julie's solution is very, very unpalatable and not easily available. So I'll recommend more of sachets, which will be easier to use in that regards. You monitor for all parameters, mainly look for their phosphorus, PTH, and urinary calcium. So now this child on phosphorus and calcitriol, still the PTH is high, which basically means that we have to increase the dose of calcitriol to avoid that and follow up for other parameters. At 2 years follow-up, phosphorus was still high, calcitriol is 25. There's polyuria and abdominal pain. They are always at risk of developing hypercalciuria. So look for nephrocalcinosis again, even if in the normal variants in that perspective, so you need to be cautious about it. What about VDDR, vitamin-dependent rickets? The treatment is, even for the milder form, you need a very high dose of calcitriol to begin with. So you need a very high dose of calcitriol, around 150 to 200. For resistant state, you will need even more, maybe 10, 20 capsules every day. So it's a very complicated scenario. So just to summarize of whatever I have talked about, the key message is, first of all, do not do unnecessary workup. Give a full therapeutic trial of calcium and vitamin D, and then if there is no response, do a workup. Or if there is severe short stature, there is polyuria, there are fractures, then you would need to do a workup, otherwise no workup. Initial workup is calcium, phosphorus, creatinine, ALP, this much is sufficient. If you have a low or normal phosphorus, do a PTH. Along with that, you do a blood gas. That will classify in most of the cases. Calcitriol, only the rarest of the rare situations in which you have got normal or low phosphorus, your blood gas is normal, your calcium is normal, your PTH is normal, then only you do a calcitriol. And on the other hand, if your phosphorus is high, creatinine will classify into two parameters. Management of hypophosphatemic rickets, RTA and VDDR requires specialist inputs. It's a more complicated process. You have to have lifelong treatment, and that becomes important from that perspective. So all of you can go and have a look at the website. As I mentioned, a lot of information is available, and the books also, which cover a lot of pediatric endocrine aspects. And we recently came up with a protocol book. Dr. Arpita is also one of the authors for that book, and you can have a look about practical protocols for pediatric endocrinology. So at the end, I have to thank all of you for patient hearing, and thanks the entire department, Shelly ma'am, Dr. Arpita, everybody for inviting me for this discussion. Thank you.
Thank you so much, sir, for such an excellent talk as always and making such a complicated topic a bit simplified for our residents and listeners. Thank you so much once again. I would like to request Arpita ma'am to present the memento to Anurag Bajpayee, sir. I would like to invite Arpita ma'am to introduce our next speaker, Dr. Arun Pandey, sir. So it's an honor to introduce Dr. Arun Pandey, sir. He is the director, ADDTC Clinic, Gomtinagar, and he's done his DM Endocrinology from SGPGI and has various publication and index journals. And he'll be talking about genetic testing of maturity onset diabetes of the young, the current status and future perspectives. I call upon sir.
Thank you, ma'am. So, thank you, organizers, to invite me for this talk, and thank you, MedGenome. Although this slide, the template is of MedGenome, but slides are made by me, and all the components, all the cases are from our group. So I'll be going through my talk under following headings: introduction and types of monogenic diabetes, then next generation sequencing, neonatal diabetes, then the most famous part of monogenic diabetes, that is MODY, clinical relevance of diagnosing monogenic diabetes, when to suspect it, our data, then new knowledge which is there with MODY, and conclusion. So this is the first case, 23-year-old set-top box mechanic who was diagnosed with diabetes recently for 1 year, which was detected accidentally as he sustained a wound after a road traffic accident. Came with complaint of diminution of vision gradually in both eyes. His BMI was 18.9, waist circumference of 0.89, and he was not having any acanthosis nigricans. So this is the family tree. And if we see those with light blue boxes and circle, they were all affected with diabetes. So this is our index case. And even individuals of next generation who were of 4 years, 5 years, they were having diabetes. So that was my first encounter with MODY during my DM residency days. Unfortunately, those were the times when genetic testing was not much available, and we could not do much for that except for manage diabetes. So if we see monogenic diabetes, it results from one or more defects in single gene or chromosomal loci. It can be dominant, recessive, non-Mendelian trait. It may present as a spontaneous case due to de novo mutation. Parents cannot have it. It usually forms around 2 to 6% of pediatric diabetes. So there are 4 types. Many times people confuse between monogenic and diabetes. Monogenic diabetes is a broad term. In that, neonatal diabetes is a category which is self-explanatory. Individual, they develop diabetes usually in early infancy. Then MODY, diabetes associated with extra pancreatic features, then monogenic insulin resistance syndrome. So there are 4 types of monogenic diabetes: neonatal diabetes, MODY, diabetes associated with extra pancreatic features, and monogenic insulin resistance syndrome. NGS is obviously the investigation of choice, as it tests for multiple genes simultaneously, except if suppose one is suspecting that the patient is of GCK MODY, then we can go for specific gene testing. Otherwise, most of the time, NGS would be required to diagnose the MODY. So coming to a case, this is a 4-month-old male child who is born out of second-degree consanguineous marriage. His weight is 6.1 kg. He was managed with insulin. His sample was sent to Exeter University, UK, but it came out to negative for monogenic diabetes. At the 8 months of age, he stopped requiring insulin. So a diagnosis of transient neonatal diabetes was made. So coming to neonatal diabetes, any case of diabetes when you diagnose below 6 months of age, that's the time every patient should be sent for gene testing. If antibodies are negative between 6 to 12 months, then go for the gene testing. A molecular genetic diagnosis can help us to decide for the treatment option. Some form of neonatal diabetes, they can respond to oral agent, or what associated features they can have, whether they'll have just diabetes or some other neuropsychological symptoms, or if suppose they have any whether that would be transient or permanent. So some form of neonatal diabetes that can be transient. So if suppose gene testing is done, we can come to know that these individuals have transient neonatal diabetes and they'll not require treatment for lifelong. So KCNG11 and ABCC8 are the 2 types of MODY which the neonatal diabetes who would respond to sulfonylurea. And they along with the diabetes, they'll have some neuropsychological symptoms. Treatment with glibenclamide not only improves the diabetes, but also it improves the neuropsychological outcomes. Also, as early the treatment is started, better is the outcome. So we have seen about monogenic diabetes, introduction to it, then classification, and we've also seen what is neonatal diabetes. Now about MODY. MODY, it is a clinically heterogeneous group of disorder characterized by non-ketotic diabetes mellitus. It is an autosomal dominant mode of inheritance is there. It is usually has an onset before 25 years of age, and frequently it is seen in childhood and adolescent. Primary defect is in the function of beta cell of the pancreas. So when one should go for MODY testing is that when there is family history of diabetes in a parent or first degree relative with affected persons with diabetes who lack typical feature of type 1 or type 2 diabetes. Testing for GCK MODY should be done in individuals who have mild fasting hyperglycemia. That's the time when it should be done. So we have seen about MODY. Now, what are the clinical features of MODY? When we should think of MODY? Now let's go through a case which will help us to understand what are the features of MODY. So this is a 23-year female who had diabetes at age of 18 years. Her mother died at a young age and she had renal complication along with diabetes and she died in late 30s. Ultrasound of this patient showed renal cyst. So right at the OPT, first OPT visit, we made a suspicion that this patient is having MODY type 5 and a genetic evaluation was done. What was seen is that an HNF1 beta mutation, which was expected, it came out to be positive. Along with that, a BLK mutation came out to be positive. So this was a novel variant of HNF1 beta and BLK mutation. This is the first time to our knowledge, this is the first case in the literature having combination of involvement of these 2 genes. So what are the features of MODY? If you see HNF1 alpha and 4 alpha, they have usually autosomal dominant pattern of inheritance. There are specific features like renal development abnormalities in HNF1 beta, macrosomia and neonatal hypoglycemia in HNF4 alpha, exocrine pancreas dysfunction in cell MODY, hearing defect in mitochondrial MODY. Then obesity alone does not preclude for genetic testing, as obesity is on rise. Many times individuals, they might have obesity and still they can carry this gene. So if suppose somebody is having typical autosomal dominant pattern of inheritance And there are family members who are affected, but they don't have typical features of metabolic syndrome. Then also we can go for the MODY testing. The HNF1 alpha and 4 alpha, they respond well to sulfonylurea. Mild fasting hyperglycemia, it happens in GCK MODY. Establishing a correct diagnosis is very important so that we don't misdiagnose them as type 1 or type 2. And also, if suppose we diagnose them properly, we can predict the complication. As in case of MODY type 5, the renal complications are very common in them. It may avoid stigma or limitation with employment, like somebody is having labeled as diabetes GCK MODY. These are the individuals, they will not require any treatment. There are 40 years follow-up study which has shown that there was no increased risk of complication. So a stigma around employment can be taken care of there. So it enables testing of other individuals in the family and reclassification of the diabetes. So there are this 5-6 more common cause of MODY. So GCK MODY, it causes mild asymptomatic hyperglycemia. HNF1 alpha, it causes renal glucosuria. HNF4 alpha, it causes macrosomia and immune-related hypoglycemia, renal Fanconi syndrome. Then HNF1 beta, it causes renal development abnormality and genital tract malformation. KCNJ, it causes transient into diabetes along with neuropsychological dysfunction, and also similar is the pattern in ABC. All of them, usually they respond to sulfonylurea, except for HNF1 beta. But we have one case I'll show in the next slide, wherein individual was having HNF1 beta mutation, still he was responding to sulfonylurea. So it's very important not go by the textbook, because it's an evolving field. Many a times we might see differences what is there in the literature. So like this was a 27-year-old shopkeeper who was diagnosed with diabetes at 18 years of age. His blood sugar was 550. His A1C was 12, lean body habitus, osmotic symptoms. His mother, siblings also had diabetes. Given that he had high blood sugar, osmotic symptom, he was advised to take insulin, but it declined despite repeated persuasion. His ketones was negative. With patient's assurance that for regular follow-up, he was started on glimepiride 3 mg. He responded well to medication. His blood sugar came down from 500 to 110, fasting and postprandial of 180. So this led to a suspicion of MODY, hence a genetic evaluation was done, and what it came out to that HNF1 beta variant. His brother, who was diagnosed with type 1 diabetes for 5 years, he was receiving insulin. We could switch him from insulin to sulfonylurea. He responded well to that, and he is still now responding to sulfonylurea. So based on this ACMG guideline, this variation was classified as likely pathogenic. So this was a case which we found in 2017. But recently, of late, 2 years back, there was a case report of SNF1 beta MODY who was responding to sulfonylurea. So what's the clinical relevance of diagnosing MODY? It makes specific molecular diagnosis so that we can decide what should be the pharmacological management. Characterizing the specific molecular diagnosis can help the genetic counseling. It may trigger genetic testing in other family members, and one can find mutation in the other family members and reclassification of the diabetes in the other family members. So we have seen about what is monogenic diabetes, types of it, then neonatal diabetes, MODY, then what are the clinical features of that. Now, when to suspect MODY in an individual wherein we are thinking that this patient is of type 1. So I'll share a case. This is 11-year master IP. He was having recently diagnosed diabetes. He was having fatty liver. His father is affected with diabetes. GAD antibody, CRM I2 antibody was negative. He was suspected to having MODY, and then we sent the sample for gene testing, and it came out to having PDX1 mutation. He responded well to glycoside and metformin. His A1C dropped from 13.6 to 6.4, challenging the usual belief. Until now, there are no case reports of PDX1 MODY responding to oral agent. This is probably one of the first cases wherein PDX1 MODY is responding to oral agent. We sent a sample of the parents, mother and father. Father, who was symptomatic, having diabetes, he also harbored the same gene. So as the family screening was done, it came out that the symptomatic father was carrying the same mutation, and if there is ACMG scoring done for the mutations, and as the father was having this mutation along with diabetes, this mutation was later reclassified as likely pathogenic. So what we have seen is that those individuals who have antibody negative family history is there, then there it is important to go for genetic testing. So the individuals less than 6 months onset of diabetes, that's the time when we should go for gene testing. If antibodies are negative between 6 to 12 months of diagnosis of onset of diabetes, if persons with diabetes have some congenital defect, then that's the time when we should go for genetic testing. First degree derivative of affected parents, they should go for genetic testing. If suppose beta cell function is preserved, one exception to this rule is KCNJ MODY. KCNJ MODY, there the C-peptide can be negative, still they can respond to sulfonylurea. So that's a place wherein C-peptide, if we done, it is negative, still we can miss KCNJ 11 MODY. So that's a place sometimes I don't like to use C-peptide because we might miss cases with KCNJ 11 MODY. So we have seen where to suspect MODY in case of individuals with type 1. If suppose we have found that patient is having type 1 diabetes, but antibody comes out to negative, that's a time when we should go for gene testing. Now, another case, this is a 37-year businessman who was having diabetes for last 19 years. His sugar was 156, postprandial of 280. He was currently taking 4 oral agents. Still, he was not responding. The sugars was on a higher side. He was an exercise enthusiastic. He was exercising for 1.5 hours. Still, the sugar was high. His BMI was 25. Acanthosis nigricans was negative. So it's very important to see for acanthosis nigricans if that is negative. So this case will help us to differentiate between when to suspect MODY in individuals who have type 2 diabetes. So this was the initial family tree which he gave to us. This was the index case. Genetic testing was done, and the daughter, she was a carrier for this mutation. This was an extended family. This is a case and the carrier offspring. Recently, one of the distant relative of this patient, her daughter came with diabetes, and she came out to having a digenic mutation which is involving HNF1 alpha and 1 beta. So gene testing was done to CMC Vellore. This was the first case which we could genetically prove. This was around 2-3 years post my DM days, and it responded well to glimepiride 3 mg, and genetic testing was done to CMC Vellore, and it came out to be positive, and it was likely pathogenic. This is the Sanger sequencing of the patient and the offspring. Both were carrying the mutation, and what was seen is that at age of 11-12 years, the postprandial sugar was 177 and 181. If you see this graph, this is a typical feature. They'll usually have HNF1 alpha, they'll have normal fasting sugar, but the post-glucose sugar would be high. This is just opposite of that of GCK MODY, wherein there is fasting hyperglycemia, while in HNF1 alpha, there is postprandial hyperglycemia. The non-carrier offspring, the sugar profile was absolutely flat. This case we presented in a European Association of Study of Diabetes conference in 2017, and it was much appreciated there. So when to suspect MODY in individuals who have type 2 diabetes? In young individuals, as the obesity is on rise, there was this recent paper what it showed that 3% of obese youth who was presumed to having type 2 diabetes, they actually came out to be monogenic diabetes. So if suppose there is autosomal dominant pattern of inheritance, but there is lack of severe obesity among affected family members, then one should go for genetic testing. No acanthosis nigricans, no features of metabolic syndrome like hypertension, low HDL cholesterol, then one should go for genetic testing. Then unusual fat distribution, central fat, that's the time one should go for genetic testing. So if this is our data, we have up till now, we have sent sample for 53 patients whom we suspected MODY, of which around 19 cases, that is 35% of cases, they come out to have MODY. And if we see, there are series from South India, like this was a series from CMC Vellore, wherein 11 cases was diagnosed with MODY. This was a time wherein they were setting their lab. Then the second time CME again did a study during, this was in the scenario of pregnancy. While Dr. V. Mohan from South India, they were trying to discover new gene for MODY, and that's the time they could find 21 cases of MODY. Then there was this another series from North India wherein they just searched for one gene, that is HNF1 alpha. Our case series, we have seen almost all the mutations of MODY except for GCK. Also, one surprising thing was that Neuro D1 MODY, which was common in South India, but it is not seen in our series. So we have not found any case of Neuro D1 MODY. Also, there were other genes which are not typical of 14 genes which are described for MODY, but we couldn't find 4 other cases of non-typical genes of MODY. So during the course of diagnosing so many cases of MODY, we have learned few things. In spite of strong suspicion, few cases might come out to be having variant of unknown significance. Like one of the cases wherein there was KLF11 mutation, bioinformatics, it came out to be damaging. Still, it was reported as variant of unknown significance. So in order to report this mutation as pathogenic, more data is required. Also, it is very important to check whether the reports which was received as variant of unknown significance, whether it is converted. There are some online databases like clinggen.org. They update their mutation status. That's a place where we should check for what is the status of current mutation of that. Then there is one new important thing which I want you to know is the digenic mutation. Now we have 3 cases of digenic mutation. There is a library for that, digenic.com, but recently that has been overhauled for better data data for MODY, and it is now called as OLIDA. We could not find any combination of 2 digenic mutation which was there, which we seen in a practice in this library. So, and there is one important term called as MODY-X. We might have strong suspicion of MODY, still the gene mutation there cannot be gene mutation. So we had 2 cases of predominantly fasting hyperglycemia with almost no complication. Also, there was family history suggestive of similar pattern, a strong suspicion of GCK MODY, but still it came out to be negative. It would be interesting to see what kind of mutation these people have in future. There are 2 common ways to detect novel mutation. One is by candidate gene identification, that's the way why GCK MODY was diagnosed, and other by doing genome-wide association study. We hypothesized that about 2 cases wherein there was fasting hyperglycemia, this could be due to gene mutation upstream or downstream of glucose kinase sensing pathway. Also, there were few cases wherein we had strong suspicion of MODY based on clinical characteristics like lean, young onset diabetes, strong family history, responsiveness to sulfonylurea, but still it came out to be negative. This clearly indicates that there are a few more forms of MODY who are sulfonylurea responsive, but candidate gene has not been identified, and probably we'll see more novel genes in future to come. So, if we see, there are so many cases which we have diagnosed, and each case is a story in itself. Because of paucity of time, I'll skip that. And what does the ISPAT guideline also says that reference to specialist in monogenic diabetes or interested clinical geneticists should be suggested to guide specific management, facilitate genetic testing or other related affected in pre-symptomatic individual. What's new in monogenic diabetes? There has been this new genes which has been found, C01, 1CUT1, and so on, and few new genes in causing diabetes later life, like TRMT10A, DNA JC3, KCNK16, that they have been found out. Now there was this IPEX syndrome. It can cause diabetes, type 1 diabetes less than 6 months. There is also one condition, trisomy 21, wherein it can cause autoimmune type 1 diabetes in less than 6 months of age. Among persons with diabetes with strong clinical diagnosis of type 2 diabetes, obesity should not be a factor wherein we should which should stop us for going for testing. This was the new recommendation in the ISPAT. Rate of diabetes-related complication may be lower in HNF1 alpha diabetes who have been treated with sulfonylurea, Then there is this new thing that liver transplantation with or without pancreas can improve outcome in Walcott-Rallison syndrome. To conclude, monogenic diabetes as a cause of diabetes due to mutation of single gene accounts for around 2.5 to 6.5% of pediatric diabetes. Many newer mutations are being detected. Around 80% of monogenic diabetes cases, they are misdiagnosed as either type 1 or type 2. Clinical feature and investigation can help to diagnose MODY. Diagnosis can help for better treatment, prognostication, and genetic counseling. So this is my acknowledgements. And thank you for your patient listening.
Thank you so much, sir. And with sir's talk, it's clear that MODY should be kept as a possibility not only in type 1, but also in type 2. So with the availability of genetic testing, the list of MODY classification is ever expanding list. So thank you so much, sir. I would like Singh sir to present a memento to Dr. Arun Pandey, sir. With that, we come to the end of a day-long CME. I would like to thank Shelly Vasti ma'am for conceiving this idea of the CME and all the faculty members who took out time to be here, and all the participants, my residents and other staff members who helped me with the CME. Thank you so much. So, thank you, ma'am. So the high tea with the snacks are waiting for you. Close. Thank you.